been a civil servant, I think, since April of 2003, and you've held a number of posts, not just in the Department of Health and Social Care, but also the Cabinet Office and the Government Equalities Office. Is that correct?
Yes, it is.
And were you appointed to the Senior Civil Service in April of 2013?
Yes, I was.
From November 2014 until June 2015, were you one of the two deputy directors in the Department of Health and Social Care, leading on the response to the Ebola outbreak?
Yes, I was.
And most significantly, are you currently director of the Directorate in the Department of Health and Social Care, which is the Directorate of Emergency Preparedness and Health Protection?
Yes, I am.
And have you been in that post since February of 2018?
Yes.
Could you assist us, please, in broad terms, with the nature of the functions discharged within that directorate? We've heard a considerable amount of evidence about the various functions in the Department of Health and Social Care, and I therefore want to ask you what that particular directorate is concerned with. Is it, by way of commencement, the directorate that discharges or plays its part in discharging the duty on the Secretary of State for Health and Social Care by virtue of being a Category 1 responder under the Civil Contingencies Act 2004?
Yes, but allow me to set out broadly where my responsibilities in the Directorate fall, and they broadly fall into two different areas. I have responsibility for health protection and health security policy.
Can I come back to that, Ms. Reid?
Of course.
There is a method to my madness. I wanted you to set out generically the functions of the Directorate before we look at health protection and health security. So one of the major functions of the Directorate is to discharge the duty on the Secretary of State by virtue of being a Category 1 responder under the CCA. Is that correct?
It is, yes.
Is another responsibility to discharge whatever functions are imposed on the DHSC by virtue of being the lead government department when it comes to health emergencies?
Yes, it is.
Is it also part of your directorate's functions to be concerned in that risk assessment process?
Yes, it is.
Of which we've heard. And is it also your directorate which liaises with bodies such as the United Kingdom Health Security Agency and NHS England and the Department of Levelling Up and Housing and Communities when it comes to assessing risk, managing risk, preparing for health emergencies?
Yes, it is.
And importantly, given the extent of the burdens on you, is that why your directorate, the Emergency Preparedness and Health Protection Directorate, has led the DHSE's response to all the major incidents to which you speak in your statement? Monkeypox, the Novichok poisoning, the heat wave of 2022, and so on and so forth?
Yes, it is.
All right. So you've referred to health protection and also to health security. What are they and what is the difference between them?
So health protection and health security policies form part of half of my responsibility. The types of policy that we have responsibility for in that area includes pandemic preparedness, emerging infectious disease, antimicrobial resistance. They are essentially about how the public health is protected, but also what threats under infectious diseases, emerging diseases and pandemics may well be a risk to public health.
So that's all under health protection?
And health security.
Are they together?
Yes, they are.
All right. Your statement refers to the Directorate having three branches, and you distinguish between health protection and health security, but are they in fact the same area?
They are very closely related to each other and sit very closely adjoined.
So which branch does the topic of pandemic preparedness fall under?
Predominantly under health protection.
Right. Is there in your directorate a third branch called the Operational Response Centre?
Yes.
What does that do?
So that covers the responsibilities you set out at the beginning of the questions, which relate to the discharge of the Category 1 responder capability, and is about how we prepare for threats and hazards that impact on public health and how we respond also to those threats.
So is it an emergency management centre? Does it deal with crisis management?
It does. It delivers emergency preparedness, resilience and response.
And is the history, the etymology of the Operational Response Centre, that it was first created within health and social care to deal with the necessary preparations for the no-deal EU exit, but latterly it is now the Crisis Management Centre in the Department of Health and Social Care that deals with all emergency preparedness, response and resilience issues?
That's not quite right. The department has had a long-standing function that deals with emergency preparedness, resilience and response, and that was always part of the responsibility of this directorate and was part of my responsibility when I took the post in 2018. In preparation for a no-deal exit, we also developed an operational response centre that was focused on those particular capabilities for that threat. And following the exit from the European Union, we merged both of those functions together to form what was then called the Operational Response Centre. That brings in EPRR responsibility as well.
I'm going to have to task you about your use of the word function. It's a word that
I apologise.
No, don't. There's no apology required. What do you mean when you say it had different functions? Do you mean there were different rooms, different operational response centres, different groups of people, or it was the same group of people just doing two different jobs?
It was, so functions, by functions I mean a set of capabilities of ways of working that we use to manage an emergency. In emergency response, we had ones that dealt with broader threats, and in the Operational Response Centre, these were particular sets of products and ways of working that were specifically focused on no-deal exit.
All right, so different jobs, but they were the same people. They were just dealing with at different times no-deal exit preparations or general EPRR responses?
No, they were different people. We maintained a capability to make sure that we were ready for any type of emergency, separate from the work we did to prepare for a no-deal exit. Right. They were in the same part of my directorate, but they were different sets of people.
Right, that's clear, thank you. Milady's heard evidence about the high-level risk register that was held in the Department of Health and Social Care, and a departmental board meeting which held what was called a risk deep dive into major infection diseases within the department, how the department would respond. Could we please have 22738 on the screen? This is a document, Ms. Reid, dated the 28th September 16, so it's before your time, because, as you've told us, you've been in post since February 2018. If we look at page 2, please, would you just read the middle bullet point within the red box?
Thank you.
At the time that you took up your position as director of the relevant directorate, to what extent did you understand that steps had been taken to address that plainly very serious and real concern? Were you told what had been done to raise awareness of the risk and to plan for the immediate mobilisation of a large number of staff in the Directorate?
I was not made aware of that particular commitment or issue raised in 2016.
Were you not told by anybody, Miss Reid, congratulations, you're the Director of the Directorate. You need to be aware that the main departmental board for the entire department, the DHSC, stated 2 years before there was a very real concern that the entire Directorate would be rapidly overwhelmed in the event of a major pandemic. And this is what we're doing about it.
At the point that I took over the post, we did think about the resourcing models and methods for escalating and scaling up our resource if it was needed, but that was never aligned to this discussion in 2016. It was part of our regular resourcing considerations.
Could we have the minutes of that departmental board meeting at 57271, please, page 6. Again, I emphasize, before your time, but there are, on page 6, I'm just going to refer you to them and then give you time to read them, paragraphs 25 and 26, these words: it was more likely than not that even a moderate pandemic would overrun the system. So not the department, in fact, but the system, the government. At the extreme, there would be significant issues if it became necessary to track or quarantine thousands of people. And then at 26, concerns are expressed about how resilient the somewhat fragmented system would be, that is to say, the government system for preparedness. So would you just like to just reflect on those two paragraphs, and then I'll ask you some questions.
Thank you.
Do you recall, when you took up post, anybody briefing you about the serious concerns expressed by the Department of Health and Social Care's own departmental board about whether or not there were systems in place to track or quarantine thousands of people in the event of even a moderate pandemic?
There was no discussion with me about quarantining.
What about track and trace? Anything about that?
There was no discussion with me about track and trace.
All right. And then in relation to paragraph 26, did anybody at your quite senior or very senior level in the department say, Miss Reid, we've got concerns about how fragmented the system for preparedness in the United Kingdom has become? This is something that your Directorate is going to have to grapple with.
In the terms in which you set out, no. But the process for how the system would respond to a pandemic, and by the system I mean organisations in health and social care, was both a factor of our pandemic flu readiness programme, but also one of the learnings from Operation Cygnus. So the intent of that paragraph and the issue relating to system overload was something that I was aware of, yes.
In essence, these concerns were being addressed because there were boards and systems and procedures otherwise in place to try to make sure the system was better prepared.
Yes.
Right. Well, we'll look then at those boards in a moment. An important part of your Directorate's preparedness arrangements was its, and I'm now going to slip into the terminology, its ownership of a 2011 pandemic influenza strategy.
Yes.
Was it not?
Yes.
Because that was a strategy dealing with influenza pandemic, a health emergency, and therefore by definition something within the reach of the Department of Health and Social Care.
Yes.
Or the Department of Health, as it was then known. Can you recall what you understood when you took up your post about the efficacy, the appropriateness, the adequacy of that strategy, whether it was a good strategy, whether confidence was placed in it, whether it needed refreshing, whether it needed updating or wholesale revision. Can you recall what the state of play was?
As I recall, the view was that the strategy included important component parts that would be used for a pandemic influenza, that it had been tested through exercise Cygnus, and there were elements of that needed to be enhanced, and that there was a work programme underway through the Pandemic Flu Readiness Board to deliver that.
Were you concerned by the fact that exercise Cygnus itself had concluded that the UK's plans, policies and capability for preparedness were not sufficient to cope with the extreme demands of a severe pandemic? So you've referred to Cygnus, and your answer essentially is, well, I understand that Cygnus, which had taken place before your time again, had addressed elements of the strategy. But the exercise Cygnus conclusion was rather more serious than that, wasn't it?
It was very clear that there was a lot of work that the department needed to do to improve its readiness for pandemic influenza. If the question you're asking was I concerned about that? Yes, I was concerned about that, but I was also aware that by the time I'd started in my post in 2018, a programme of work had been established to address those concerns.
And it was therefore of central concern to you that those programmes should continue because they were put into place for a good reason, namely to meet the serious concerns of this, of the departmental board's observations, the outcome of exercise Cygnus, and a clear understanding that the 2011 strategy needed at the least some work doing on it.
Yes.
All right. That 2011 strategy was the only pandemic scale strategy, wasn't it?
It's the only one that was centrally run by the Department of Health, yes.
Well, pandemic is a health emergency. It goes to the heart of your department's functions. Who else would have an overarching health emergency related strategy for pandemic influenza?
I would expect that key organisations responsible for delivering pandemic influenza response would also have thought through and have plans in place for how they would respond. So that would include NHS England, Public Health England and local delivery partners.
In the event of a national crisis, in the event of as it turns out, a catastrophic health emergency, the Department of Health and Social Care is the lead government department which drives forward what is required to be done to prepare for and initially, at any rate, respond to that crisis.
That's correct.
So what other strategies for dealing with a pandemic scale catastrophe were there than this single document?
The Department of Health owned the single document for the strategy for pandemic influenza preparedness.
Right. And it was the only strategy document, was it not?
Yes.
There was no strategy document for anything other than an influenza pandemic.
That's correct.
Could we have 22708, page 14? Three bullet points from the bottom in paragraph 2.21, there's a reference to the intrinsic unpredictability of influenza pandemics. Ms. Reid, could you just have a read of that bullet point, please?
Thank you.
You are not by training an epidemiologist.
No.
Why did no one in the Directorate, with an eye to that bullet point, ask himself or herself, we have a strategy for dealing with influenza pandemic, but because influenza pandemics are intrinsically unpredictable, and because we may be struck by a pandemic that is not influenza, but is another viral respiratory outbreak that is equally unpredictable as influenza and therefore equally catastrophic. We need to have plans for that eventuality. Why was that question not asked?
The preparedness we developed for pandemic influenza was based on the reasonable worst case scenario. So effectively, every renewal of that risk assessment did ask whether what the scenario would be that we ought to prepare for. And on successive risk assessments, the risk assessment was the pandemic we should prepare for was a pandemic influenza.
But those very same risk assessment processes referred, of course, to the possibility or the risk of a non-influenza pandemic. And those same processes stated in terms that there were inherent variabilities, that the pandemic, the next pandemic, might or might not be influenza. It might have the same characteristics. It could be just as deadly or more so. It could have higher transmission or less transmission. It could be just as severe or less severe. Where were the plans for dealing with those eventualities?
Well, the plans that we developed and the mitigations we built were based on the risk that we had been informed was the most likely risk that experts advised me and colleagues that was the highest risk, and that was of an influenza pandemic. Alongside the influenza pandemic is a risk that relates to emerging infectious disease. And in that risk scenario, we had prepared mitigations and responses that would respond to that risk should that risk materialise.
But you know very well, of course, that that risk, the emerging infectious disease risk, was predicated upon and assumed confinement to health setting outbreak. That is to say, it wouldn't extend probably beyond health settings, and that there would be a very small, relatively speaking, number of casualties and an even smaller number of fatalities.
Yes, that's correct.
Yes. Could we look at page 57 in this document, please? The 2011 strategy assumed, and we can see it paragraph 7.5, that staff absence is likely to be significantly higher than normal across all settings, all sectors. Levels of absence may vary due to the size. And then if you could scroll back out, please, and in the middle of the page, 7.4. The government will encourage those who are well to carry on with their normal daily lives. The UK government does not plan to close borders, stop mass gatherings, or impose controls on public transport during any pandemic. Any pandemic. Between 2011, when this strategy was first made, Ms. Reid, and 2020, when the non-influenza pandemic struck, are you aware in the Department of Health and Social Care of any person at any time questioning that statement the UK government does not plan to close borders, stop mass gatherings, or impose controls. Was there any debate about the possible necessity of border closings, self-isolation, quarantine, mass quarantine, mandatory quarantine, or anything of that sort?
I'm not aware of any conversations on those areas of mitigation, no.
Could we have 23131, please? This is a pandemic preparedness meeting dated November 19, so on the eve of the pandemic, Miss Reid, but about a year and a half after you had taken up your post. It's a meeting of in fact, the Department of Health and Social Care. So it's not, I think, it wasn't a PIP meeting or a PFRB meeting. We'll come back to those in a moment. It's just a departmental meeting. Page 5. I'll read out the relevant bit and then give you a moment to find the part on the screen. On the right hand side, don't please scroll in because I'll lose my way, but on the right hand side there is a heading, areas of work not prioritised for the next 6 months. Adult social care, the briefing paper which outlined plans to augment adult social and community care during a pandemic was agreed by the former CMO, Professor Dame Sally Davis, the CSA and the CNO in July 18, DHSC Policy and Social Care Team to work with National Health Service England and Improvement to agree next steps. The Pandemic Influenza Public Health Communication Strategy, the content was signed off but it needs further work. A concept of operations document to outline the command structure and the responsibility of departments needs to be developed for use in an influenza pandemic. And then refresh of UK pandemic influenza strategy, update the content of the strategy to ensure that the UK pandemic influenza preparedness and response policy is accurate and up to date.
Thank you.
These areas of work which were not prioritised were of fundamental importance, were they not, to the United Kingdom and the Department of Health and Social Care's ability to be properly prepared for a pandemic?
They were important pieces of work in the pandemic flu readiness programme, yes. They were not the areas of priority.
Are you suggesting, Ms. Reid, that the bringing up to date and making accurate of the United Kingdom's sole strategy for influenza preparedness was not a matter of very considerable importance?
No, sorry, allow me to clarify. These pieces of work were important as part of the pan-flu readiness programme, and they were important pieces within that programme. However, as I am happy to expand, at that period of time in readiness for the potential disruption of a no-deal exit, my view at that time was preparing for a no-deal exit took precedent over completion of some of these pieces of work for a short period of time.
Did you or anybody else, when confronted with, and it was a cabinet direction, wasn't it?
Yes.
Work must be, to use the etymology, the terminology, work must be prioritised. The euphemism for the cessation or interruption or complete stopping of other work streams in order to be able to focus on preparations for a no-deal EU exit. That came from the highest level, did it not?
It did, yes.
It did. Did anybody in the Department of Health and Social Care, which bore the primary responsibility for getting the country ready for a health emergency, say, these important, you use the word vital, these vital parts of pandemic preparedness cannot afford to be stopped.
If I recall the process at the time, I was asked to look at which areas of work we would prioritise and deprioritise in order to prepare for a no-deal exit. And in thinking through which areas of work I would deprioritise and prioritise, I recall a submission going to ministers to set out which areas of work I would recommend that we prioritised and deprioritised. On the case of adult social care particularly, I think it may be helpful to add that my concern about the impact of adult social care as a result of a no-deal exit, a real and credible threat to that sector, was that that sector needed to prepare for and ready itself for a no-deal exit over the risk of a pandemic preparedness.
The concern that flowed from not being ready for a no-deal EU exit in the adult social care sector,
yes,
was that there would be an interruption of services, that's to say the availability of staff to work in the sector because of problems with employment and the ability of individual members of the workforce to work in the United Kingdom after a abrupt and traumatic no-deal exit. Also, the supply of medicines, probably.
that's correct.
So the two areas were workforce availability and supply chains.
I would say they're two of the areas
What were the
of
others?
concerns. I think financial stability of that sector was a particular concern before a no-deal exit, and at that time we weren't certain what additional financial pressure would be on the sector as a result of a no-deal exit. So that was an additional concern.
Was it ever seriously considered by anybody in your department that one of the consequences of an unprepared no-deal EU exit would be death? The deaths of very large numbers of inhabitants of care homes?
I think that the human aspect and risks associated with that relating to a no-deal exit were considered. I don't have the details of what the risk assessment said of a no-deal exit, but the risk of harm to the public was absolutely a consideration.
In the risk assessment process, and the procedure was updated, as you know, in 2016 and then 2019, what was the assumed outcome of a severe influenza pandemic on the United Kingdom in terms of fatalities?
If I recall, I believe the number to be about 800,000, I think, but I'm recalling, I might have that number incorrect.
Around 800,000 deaths, of which, if the pandemic were to be particularly dangerous to the elderly, a significant proportion of those deaths would be in the care home sector, would they not?
I would believe so, yes.
Yes. So let me put the question again. In terms of the balance between the possible outcomes of an unprepared no-deal EU exit and the appalling loss of life attendant upon a pandemic for which no preparedness had been carried out, why did no one say we cannot afford to stop the pandemic preparedness?
I think in response to your question, there's a couple of points I think are important to make. The first one is that the adult social care sector had done some work in pandemic preparedness prior to the pause of the work. Secondly, I think the work that was done for Operation Yellowhammer was of benefit to our preparedness for a pandemic influenza. And then the third point I'd make is that in considering where to allocate resources, what I consider is what is a real and present and credible threat versus the risk of a threat, and to try to strike the balance between where resources are allocated. I retained team work on pandemic preparedness, but I also allocated resources to deal with the real risk of a disruption through a no-deal exit.
All right. May we then look briefly at the NSRA process to which you've referred. Can you recall what role you had in the republication of the reissue of the NSRA process in 2019?
The National Risk Register's reassessment comes to my team to lead the process for reviewing whether the risk is still the same risk. One of my team led the work on developing that risk assessment. I was aware of the work at the time that was led within my team.
Not all the risks, indeed only a very small number of the risks, fall within the reach of the Department of Health and Social Care. Of course, disease is one of them, perhaps the main one.
The department has a number of risks on the risk register. Not all of the department's risks fall within the confines of my directorate's work. We deal with emerging infectious disease risk and we deal with pandemic risks, but there are risks that sit outside my team in the other parts of the department.
Do you accept, as Ms Hammond, on behalf of the Cabinet Office, and of course the Cabinet Office and the DHSE co-chair the Pandemic Flu Readiness Board, do you accept the evidence, would you accept in relation to the DHSE, as Ms Hammond accepted in relation to the Cabinet Office, that the DHSE would have been better prepared for a pandemic if had the reasonable worst case scenario been closer, a lot closer to the realities of COVID than it was?
Yes, I think it stands to reason that we would have built the different set of responses and plans had the risk that we were dealing with been a COVID risk.
There is evidence before my lady that Dame Deirdre Hine, in her review of the swine flu pandemic in 2009, had expressed some concerns about the adequacy of the RWCS, the reasonable worst case scenario model. Within the DHSE, as far as you're aware, were concerns ever expressed about the adequacy of the RWCS model, and in particular, the risk that by focusing on the assumed worst case scenario, it could lead to a tendency to stop thinking about how to prevent that worst case scenario from actually happening?
In the way in which you ask, nobody had raised with me a concern about the process for developing the reasonable worst case, or that risk that we don't do work on the lead up to that risk occurring. And I believe that with the emerging infectious disease risk, we had complementary capabilities in two different sets of scenarios, which would have addressed where those risks would have taken us.
But of course, as you now accept, the scenario for new infectious disease was predicated on a very limited outbreak with relatively very limited consequences.
Indeed, and the mitigations that we had in place for managing that had been adequate for the outbreaks of those emerging infectious diseases I experienced over the 5 years of my appointment.
Putting it another way, because the reasonable worst case scenario for a non-influenza outbreak was described in such very limited terms, confined to health settings, relatively small number of casualties, an even smaller number, tragic though they are, of deaths, much less was required of the department to mitigate for that risk, because the risk, of course, had none of the terrible catastrophic consequences that the COVID pandemic resulted in.
Sorry,
Yes, you didn't have to do very much by way of mitigating the new and emerging infectious disease risk because the risk was described in a very limited way. It didn't have the catastrophic or national consequences that a severe influenza pandemic would have, or as COVID had.
I wouldn't agree with the statement that there was less for us to be concerned with relation to a high consequence infectious disease risk. They are extremely serious, and we work very closely with NHS England and Public Health England to ensure the plans were in place for managing that risk.
I didn't suggest that you were less concerned. I said what you had to do practically by way of mitigating the risk was a great deal less than what you had to have done had you been mitigating for a severe national pandemic.
I think it's true to say that our work on pandemic influenza was a greater responsibility for the department, yes.
And that work was framed by that 2011 strategy, which said in terms, you don't need to worry about things like borders or quarantining or self-isolation or mass test and trace, because none of it was envisaged, was it?
I would say that I wouldn't necessarily say that it was framed by that. It was the work that we did on pandemic influenza was framed by a series of documents, by exercise Cygnus, by the risk registers across that period of time. So it was a number of different documents, including the 2011 strategy.
When Mr. Hancock MP became Secretary of State for your department in July 2018, that was after you had been appointed to your post as Director of the EPHP Directorate. He was provided with a document 181825, please. I've got the wrong reference. That's his witness statement. Could we have 184105 then instead, please? Introduction to Emergency Preparedness, Resilience and Response. So this was a paper which was prepared for him. I think at his request, he wanted some more information about England's emergency preparedness, resilience and response. Could we go down, please, to paragraph 12? Following a national level exercise in 2016 and a subsequent National Security Council Threats, Hazards, Resilience and Contingencies meeting in February 17, a cross-government pandemic flu readiness board was established to develop and manage the UK's preparedness for a flu pandemic. The first year of the programme included the following work streams, and then over the page, please. Response to the adult social care and community health system, coping with excess deaths, legal, moral and ethical considerations that led to the MEAG committee being set up, keeping different sectors working with reduced staff numbers. If that could be shrunk, please. And then at paragraph 13, reference to mass casualty planning. Do you recall assisting in the process by which Mr. Hancock was briefed in relation to the general state of preparedness?
I am not familiar and cannot recall specifically adding to this briefing. I can say and can recall that when new ministers arrive, I do support Clara Swinson in producing an assessment of the very current situation of risks and threats that the department faces as part of new ministerial briefing, but I can't specifically recall contributing to this particular one.
Paragraph 12, the first few words are, following a national level exercise in 2016. Would that have been a reference to exercise Cygnus, do you think?
Looking at the reference to the Pandemic Flu Readiness Board, I would assume it was in relation to exercise Cygnus and not exercise Alice.
Yes, because it was a direct result of exercise Cygnus that the then Prime Minister directed in the NSC THRC meeting that a board be set up and a programme of work devised for the Pandemic Flu Readiness Board.
That's correct.
Looking back, are you surprised that there is no reference in this paragraph to the conclusions of exercise Cygnus, which you described earlier yourself as being concerning, to the effect that the UK's preparedness and response in terms of its plans, policies and capability were not sufficient?
No, I wouldn't say that I was surprised that it didn't go into more detail in this note. From my brief reading of this note, my assessment is that this was a very early briefing given to our Secretary of State to set out the range of threats and hazards that the department faced. In 2018, there had been a series of challenging incidents. Over the last 5 years of my role, 32 major incidents, not including anything relating to COVID. So it's very important at the very start of a Secretary of State's tenure that they're clear about our risk assessment and their Category 1 responder requirements. I would have expected reference to the high-level risks on pandemic influenza and emerging disease, but in the context of the wider threat landscape.
What was the highest risk in the entirety of the government's risk assessment procedures?
When it came to hazards, it was pandemic influenza.
And what was the lead government department for in pandemic influenza?
The Department of Health and Social Care.
So are you not therefore somewhat surprised that there was no reference to the fact that the greatest hazard risk in the entirety of the government's book of risks was a pandemic influenza, and that the national level exercise Cygnus, which dealt with the possibility of an influenza pandemic, had reached the conclusions that it did in such serious terms?
I would not have expected that document at that time to have included more information on that risk than it did. It is also useful to recognise that there had been poisoning in Salisbury, there had been breast cancer screening incidents, so it was in the context of a number of different incidents that had occurred. I would expect the risk register to have been referred to as it was in this document.
Maybe then discuss in a little more detail some of the exercises. You were concerned because you were one of the 2 deputy directors within the department leading on the response to the Ebola outbreak. So you were concerned very much with how the department did respond.
Yes.
To what extent, and I should say that, was that outbreak 2014, 15, so not when you were director of the EPHP, you weren't appointed to that post until February 18, it was whilst you were in a different post?
That's correct.
All right. To what extent were you concerned with taking on the recommendations in the report on the Ebola outbreak once the outbreak was over?
Are you talking about at the immediate time or in my current post?
No, at the immediate time. So following the outbreak, obviously there was a certain amount of learning and reports were produced dealing with the outbreak and what could be learned from them and making recommendations as to the future. To what extent were you concerned with that process?
I was involved in the lessons learned processes. There were a number of different lessons learned processes post the Ebola outbreak, and I moved to different roles that were unconnected in this area in the intervening period. So the work was continued by my colleagues.
So you were involved in the lessons learned processes, but only for a while?
Some of the lessons learned processes. There was a number of lessons learned processes.
Right. you said the work was continued by your colleagues because you moved to different roles. To what extent were you concerned? For how long were you involved in the lessons learning process?
I'm recalling that some of the lessons learned processes were operational lessons learned, and some of them were more detailed lessons learned series of sessions. I was not involved in the more formal lessons learned processes, if I can recall.
The reason I ask, Miss Reid, is that, as you will no doubt recall, one of the lessons, lesson 8 from the Ebola report, was that appropriate levels of PPE should be maintained for ongoing infectious disease preparedness. And a second lesson, lesson 16, was that consideration needed to be given to the development of the relevant powers to allow stepped interventions from port through to community. So, in a sense, social restrictions or closing of borders or management of people and gatherings. Can you recall what steps were taken to pursue those issues, to draw up further papers or develop the thinking on PPE and social interventions?
So thinking about the PPE aspect of your question, PPE and appropriate levels of PPE were part of the mitigations that were recommended on the back of the emerging infectious disease risk. Ebola is an emerging infectious disease. It's a high consequence infectious disease and would therefore have been dealt with under the mitigations for that particular risk.
Can I just pause you there? Is that a reference back to what you said earlier, which is that of the two risks, health or disease-related risks in the risk assessment process, you've got influenza pandemic with its assumed catastrophic consequences, and then you've got the much narrower new and emerging infectious disease risk with the assumed much narrower consequences, and therefore reference to PPE would be a reference to the PPE required in a health setting or in a much narrower way.
That is correct. Ebola would have been classed as an emerging infectious disease and would have been treated as an emerging disease with the mitigations that would be appropriate for the management of high consequence infectious disease. And with that, your question around PPE is the PPE advice that would be given to us would be based on how you have that intensive treatment regime for a high consequence infectious disease and what would be the appropriate PPE required to manage those diseases.
What about lesson 16 and the consideration of powers that might be required to adopt interventions in the community? So restrictions on movement or public gatherings or border controls and so on. Do you recall what work was done on those issues?
I don't recall the work that was done on those issues. I am aware that there was a view that border restrictions wouldn't be the appropriate response for an emerging infectious disease or pandemic influenza.
Of course, that's why it was the lesson in the report. But was this not something that, at least subsequently, as the director of the Directorate, you would have seen the outcome of the work done to put that recommendation into place?
I'm aware of work that Public Health England and latterly UK Health Security Agency have been doing around border measures. I'm not aware of any work that was done to restrict border access.
Exercise Alice was in 2016, wasn't it? And it was an assumed large-scale outbreak of MERS coronavirus.
Yes.
That's correct. Was that an exercise in which the Department of Health and Social Care was a participant, an organiser, or just an observer?
The exercise was run by Public Health England and the Department of Health and Social Care participated in that. I wasn't in post at the time.
But there were a number of recommendations made as a result of the report following on that exercise, were there not?
That's correct.
And those recommendations included issues such as developing plans for, or at least considering the need for quarantine, self-isolation, the collection of data from contacts, a enlarged process of community sampling. Of course, again, this was regarded as a high consequence infectious disease. It was a more limited outbreak. Do you know what happened with those lessons and the putting into place of practical measures to give effect to them?
Yes, there were two bodies of work that were set up to lead pieces of work on how to respond to those actions. One was developed by NHS England. They set up a high consequence infectious diseases programme. The Department of Health was a participant to that piece of work, and Public Health England set up a programme of work to also respond to the recommendations and the work on high consequence infectious disease. As I understand it, NHS England's board continues, and we still play an active role on that, and PHE's commitments have been embedded within their programme of work at UKHSA.
Both those work streams, Ms. Reid, were clinically related, weren't they? They were to do with how the NHS clinically would deal with the impact of a high consequence infectious disease outbreak, and how Public Health England would deal, well, I suppose, semi-clinically with the outcome of an outbreak. Where was the work done by the DHSC by way of plans for quarantine, self-isolation, enhanced community sampling and collection of data?
I would say that the recommendations were both clinical and operational, and that the clinical and operational elements of them were led by NHS England and Public Health England, with bodies that we were on to support. In your answer to your question about where the work on contact tracing was led, that was within Public Health England.
Did the DHSC, as far as you are aware, take forward, produce papers or policies or guidance or spend time thinking about any of those issues within its own department?
So the advice on clinical and operational matters would be the responsibility of NHS England and Public Health England. So we would look to those bodies to provide us with advice. I am not a clinician and I'm not well placed to write those papers. I would seek advice from colleagues across the health and social care organisations that can. We were very aware of the level of readiness in the health and social care system to deal with an emerging infectious disease. There were off memory, approximately 8 or 9 in the 5 years of my appointment. And so I was very aware of the response capability to high consequence infectious disease and had run a number of incidents to see how that operated in practice.
Those recommendations were not formulated by way of directions to NHS England or improvement or to Public Health England. They were generic recommendations or lessons. X, Y, or Z must be done. So, given that it wasn't the NHS England or the PHE who were told to respond in their own way, within the limits of their own functions, to these areas of concern, why wasn't the DHSC itself responding, doing what it could to improve the overall system of preparedness for a health emergency by addressing these particular issues?
I would say that it is within the remit of those organisations to lead the response that was required to those recommendations. And that is set in the remit letters and the responsibilities that those organisations hold to deliver adequate preparedness to an outbreak of an infectious disease and a response to public health. That is enshrined within the responsibility of those two bodies to do.
Exercise Cygnus.
Yes.
You're aware, because we've been debating it, that the overall outcome of Exercise Cygnus was that the UK's plans, policies and capability were not sufficient to cope with the extreme demands of a severe pandemic. How often, as far as you're aware, was that conclusion considered within your department once you took up post 18 months later?
Sorry, could you repeat the question?
How often was active consideration given to whether or not that general conclusion from exercise Cygnus was being dealt with? How often were meetings held where employees in the department would say, right, well, that was the serious conclusion from the exercise. How well are we doing in terms of addressing those concerns, of making sure that the plans and the policies and capability are now sufficient? How often was active consideration given to making sure that that worrying feature was being adequately addressed?
I would say on a regular number of occasions in different ways. That the concern that was raised in Cygnus was a feature of our risk and our risk register. That was discussed every level of the department on a quarterly basis. We had boards that were looking at the readiness of the health and social care system to respond to that. That was chaired by my Director General, Clara Swinson. We had quarterly conversations to look at cross-government readiness and whether we were addressing the recommendations of that report. So, and also regular meetings with our Permanent Secretary. So I think the question about how we were responding to our state of readiness was asked on a regular occasion.
How many recommendations came out of exercise Cygnus?
22, and 4 learning recommendations.
By June 2020, how many of those recommendations did the DHSC itself identify had not been fully completed?
Off my recollection, I would say that 8 of them had not been fully completed, or had been partially completed, and about 6 of them had not been completed at all.
That was, you're quite right, the conclusion of a DHSC meeting, work stream, another work stream, to consider to what degree the department, or to what degree the recommendations from exercise Cygnus had not been completed. And that was a conclusion reached in June 2020, was it not, Ms. Reid?
That sounds about the right date, yes.
All right, take it from me then.
Can I just ask what you mean by not fully completed, not completed at all? Completed means done, completed. And so I would have thought not fully completed means work had started but it hadn't finished. Not completed at all, I don't understand.
Okay, allow me to expand. Some of the recommendations had different component parts to them. And so there may be an element of a part that had been completed. So, for example, we had completed some work on surge guidance. That had been completed, but the second half of that, around socialising that with, or testing that with health and social care organisations, that part of it was not completed.
But that would come under the category of not fully completed.
I think that's a fair conclusion to reach. Yes.
So, what do we mean by 6 were not completed at all? Do we mean no work had started?
No, I wouldn't say that no work had started. Work had started on all of the recommendations. But there were some elements of those that had been completed. So I would agree with your conclusion that they weren't completed, but work had begun on all of them.
Or they hadn't got very far?
It varies across the recommendations, my lady.
If you have a recommendation that says we must get more PPE, this is a highly infectious disease, it's got dreadful consequences, we must get... Whose responsibility is it to get the PPE?
I would suggest that that would be my responsibility.
And who would ensure that your responsibility was carried out, apart from you?
That would be the responsibility of my Permanent Secretary and the departmental board.
So after Ebola, you had a recommendation for more PPE, was it?
I can't recall the recommendation from Ebola, my lady.
I think there was one in relation to PPE.
If there was a recommendation that related to PPE being acquired for an emerging infectious disease, as I understand it, the PPE stockpiles for emerging infectious disease have been adequately built. I haven't had anything to tell me to the contrary. So I can't, unfortunately before my time, I can't confirm whether or not and how the recommendations for Ebola's PPE were delivered, but I can say that hasn't been raised to me as an issue, that there isn't adequate PPE for an emerging infectious disease.
Thank you.
Can I assist you, Miss Reid? Lesson 8 from Ebola is that further work would be required between the Department of Health, NHS England and Public Health England to determine the most appropriate levels of PPE that should be maintained for ongoing infectious disease preparedness. But for the reasons that we have been debating, namely that the assumed consequences of infectious non-influenza disease were set so low, were so narrow, in terms of being confined to healthcare settings and very low levels of casualties and fatalities. Not very much PPE was required to meet what was thought to be necessary for a high consequence infectious disease, but no consideration was given at all to the need for PPE for a non-influenza pandemic. That's the sum of it, isn't it?
The risk assessment we were building our mitigations for were a pandemic influenza and emerging infectious disease, and in both of those cases, with advice from experts and specialists, we were advised what PPE we needed for both of those risks. If you start from the premise of the risk you're mitigating, you build the appropriate mitigation for those risks. So it is the case that we had appropriate PPE for those two scenarios, but not for a COVID pandemic, which was not the risk we were managing.
And going back to the recommendations, the recommendations from Cygnus, 14 of which had not been fully completed, whatever that means, 8 partially, perhaps 6 not fully completed. That was not a situation in June 2020 which took anybody by surprise, was it?
No. The recommendations that hadn't been completed were part of our ongoing programme of work. And as I mentioned earlier, some elements of our programme needed to be paused. And so there were elements of those programmes that hadn't been completed. I would also say that there are a number of recommendations in Cygnus that it's not really conceivable for us to say that we have ever fully completed. So the first recommendation is that our emergency preparedness must follow best practice. Well, by definition, we never complete that because the process is about continuous learning. So I'd never feel comfortable being at the point of saying that we've absolutely completed that activity. The way that some of the recommendations were phrased was such that they were about ongoing work and continuous development. So I think it would be difficult for us to ever get to the point that we'd say all 22 of those have been completed.
The point, Ms. Reid, though, is this, isn't it? As at June 2020, the body that was looking at how many of the recommendations were implemented couldn't have been taken by surprise. It must have been apparent to everybody who was responsible for implementing the implementations from 2016 through to 2020 that the recommendations were not being implemented. It just was not being done for a variety of reasons, which you've attempted to explain. It just wasn't done.
There were a number of recommendations that weren't completed. That's absolutely correct.
And you knew that the recommendations were not being implemented. 2016 was 4 years before this committee reported as to the number which weren't being implemented.
That's correct.
And if we could have, please, on the screen, 22792. Which is the report into exercise Cygnus, page 6. At 1, amongst the recommendations which were never implemented in full were this one, the development of a pandemic concept of operations, correct?
That's correct.
Page 8. At 3, work to be done on how the public would respond to a pandemic. That is to say, whether it would self-isolate, whether it would cope with the demands of mandatory quarantining, how it would respond to social restrictions. Correct?
I can't say with certainty whether any of the work was done on this particular recommendation. I don't think it is concluded.
No, the only thing that was done, Miss Reid, wasn't it, was that a committee was set up called MEAG, of which my lady has heard, the Moral and Ethical Advisory Group, which would give advice in the event of a pandemic on some of the moral and ethical questions that might arise.
Yes.
But the work done, the behavioural work done as to how the public would deal with social restrictions and non-pharmaceutical interventions, and how in practice the country would be enabled to deal with the consequences of a catastrophic pandemic, were not addressed at all, were they?
No.
Page 9. An effective response to pandemic influenza requires the capability and capacity to surge resources into key areas which in some areas is currently lacking. The NHS did put into place, at your department's urging, plans for surge capacity. And we saw that, of course, when the pandemic struck. But very little work was done in relation to how the adult social care sector would cope with a mass influx of patients in a pandemic.
I wouldn't agree that there was no work done in that space. There was a lot of engagement with LRFs, and some guidance was issued to adult social care providers in May of 2018 that addressed the question of surge. I would not say that that work was completed, and I would be very clear to say that there was more that we needed to do about community surge, but it was not the case that no work was done.
Page 11. There was some feedback in the course of exercise Cygnus from local resilience forums to the effect that there are just too many plans, and there's a question about how up to date all the plans are and whether there are contradictions between them. What was done in order to rewrite the plans to produce something perhaps in a single document, something that was coherent and clear to the LRFs? Was that ever done?
No, it wasn't completed.
Page 12. Some of the feedback was to the effect that LRFs, the local resilience forums, would have difficulty operating their plans and capabilities at this scale of response. More focus and coordination on plan flu preparedness is needed nationally, departmentally, and within Resilience and Emergencies Division Operations Centre itself. Now, of course, you don't speak for the Resilience and Emergencies Division of the Department of Levelling Up, Housing and Communities, nor for the Cabinet Office. But was that focus and coordination carried out, as far as you're aware?
I am aware that the Ministry for Housing engaged extensively with Local Resilience Forum around their readiness in pandemic influenza. I'm aware the Cabinet Office engaged extensively with Local Resilience Forums on their resilience standard and their level of preparedness. Of course, it's also important to note that NHS England and Public Health England are represented on the Local Resilience Forum, so I also engaged with the health system that sits on Local Resilience Forum. It was not coordinated, and that was definitely one of the recommendations that we didn't deliver, which I regret, around that coordination and the bringing together of advice. But we did engage with Local Resilience Forums and at the local level.
Ladies, is that a convenient moment?
Certainly. I shall return at 12 o'clock.
All right.
please, which is the 2016 plan, page 3, paragraph 1. Within the health sector, there are generally good levels of resilience with good preparedness and business continuity arrangements in place.
Yes.
And at paragraph 5, the health sector can be impacted by the majority of risks in the national risk assessment. It's essential within the health sector, national planners are planning against the common consequences, given the diversity and interconnectedness within the health sector and the extent to which it needs to respond to the consequences of emergencies in other sectors. Emergency preparedness, resilience and response planning adopts an all risks approach. So this is the DHSC saying we have measured ourselves against a security and resilience assurance. These are our plans for preparedness and continuity. We, going back to paragraph 1, think there are generally good levels of resilience with good preparedness and business continuity arrangements in place. It's you signing off on how you're doing. Paragraph 1.
Yes, but this is not a static status. It is something that we continually look at the health and social care sector's resilience for emergency preparedness.
Of course. So this is just for 2016?
Yes, I'm not familiar with this document.
All right. So every year or every 2 years these plans are put into place, or these documents are prepared? And they're not static, are they? They take account of whether or not there are good levels of resilience, or whether there's been an outbreak, or whether there's been an exercise, and whether you've responded to an exercise, or whatever it might be. They're not fixed, set in place. They take account of the reality of how well the department is doing.
The department and its delivery organisations, yes. And
its arm's length bodies.
Yes.
Could we then please have 2017-18 Health Sector and Resilience Plan, 105273? Page 3. So, Ms. Reid, this Health Sector Security and Resilience Plan was after exercise Cygnus. The first one I showed you was before the report in exercise Cygnus. Could you go, please, down to the bottom of the page, or halfway down the page? There we are, stop there. So this plan, a year and a half later from the earlier plan, is after Cygnus has reported in the terms that it did about the systemic insufficiency of the plan's policies and capability in the health sector, amongst others, to cope with the extreme demands of a severe pandemic. But the wording in this plan is identical. There are generally good levels of resilience with good preparedness and business continuity arrangements in place. The identical words to the plan 18 months before. So it wasn't static. It was static. The plan uses the identical wording from the earlier plan. So how could it possibly have taken account of that severe conclusion from exercise Cygnus, and the fact that the work streams which came from Cygnus were not, by and large, being pursued through to their fruition?
I'm not familiar with this document, and this document was produced before my time in the organisation, so I cannot make an assessment of the decision to draft that sentence as it is. Looking at this document for what I can see it to do is it is looking across the totality of the threats and hazards landscape. So all of the threats that are captured in the National Security Risk Assessment. I think that my perception would be that at that time the concern of pandemic influenza wasn't a state of readiness, but this is looking at general levels of resilience and preparedness across all of the risks in the National Risk Register.
Ms. Reid, in the field of health emergency, in the field of the Tier 1 risk faced by the United Kingdom, There had been, since the earlier sector resilience plan, exercise Cygnus, which had concluded in the way with which you are very familiar. How could a proper, adequate sector resilience plan conclude in this way using the identical wording that its earlier plan had used before exercise Cygnus had reported?
I can't comment on the drafting of this
because
paper,
this is before your time.
It was not before my time. I would not say that in the specific risk of pandemic influenza we were fully prepared or that there was good levels of resilience. I would say generally across the threat and hazards landscape there is a good level of resilience and a good degree of preparedness.
Was there a sector resilience plan prepared by you, however, after you were in post?
I don't believe there was, no. I don't recall producing one, no.
All right. My lady, there's a document which we have in our system which hasn't, in fact, been disclosed for a variety of reasons. I'm not quite sure why, to core participants and to the witness. And therefore not in a position to be able to bring it up on the screen, and it's not right that I should, because it'll take everyone by surprise. But I want to ask you, Miss Reid, do you recall a sector resilience plan for 2018 and 2019 being prepared whilst you were and remain in post?
I don't recall a plan being produced, no.
All right. If that plan were to use these words, there are generally good preparedness and business continuity arrangements in place, that would seem to indicate that the wording had still not been materially altered even by 2018-19 when you were in post.
I can't comment on the text. I'm not familiar with the document. If the text is the same as the previous versions, that would imply that it hadn't been changed. That would not be my view of the pandemic risk, but it would be my overarching view of our state of readiness for wider threats and hazards.
All right. The Pandemic Flu Readiness Board, we've covered the work streams which were meant to be addressed by the Pandemic Flu Readiness Board. Bringing those threads together, the board was established in
2017.
In March, following exercise Cygnus. It was established by order of the National Security Council Threats, Hazards, Resilience, Contingencies Committee in the order of the then Prime Minister.
Yes.
It had a number of work streams, some of which were completed.
Yes.
Some were part completed. Some were not completed at all. We needn't go into the detail of it. But that Pandemic Flu Readiness Board, which was a board chaired jointly by your department and the Cabinet Office, didn't sit at all, did it, between November 18 and November 19?
That's correct.
You've already explained, and other witnesses have explained, that that was because of the necessary preparations for a no-deal exit. Operation Yellowhammer interfered in this process. But why did the fact that the particular work streams were in some places being paused or not completed mean that the board itself didn't have to meet between November 18 and November 19? Why was Operation Yellowhammer a sufficient explanation for why the board didn't meet, as opposed to why some of its work streams were not being seen through to their conclusion?
I would say that the reason for that is that our prioritisation of resources in working on pandemic flu were prioritised at the delivery of key elements of the programme rather than in the secretariating of a board. So I prioritised our work on the bill and on work to do with excess deaths and MEAG rather than board secretariating functions. So the work continued, but we didn't run a board.
You were the prime civil servant along with Miss Hammond on that board.
Yes.
You effectively co-chaired it.
Yes.
You knew the board was not sitting and did not sit for a whole year.
That's correct.
Did you not think to yourself, the risk of a pandemic has never gone away. These are important work streams which the Prime Minister ordered to be done. They are things that matter. They reflect the conclusions of exercise Cygnus. They are important aspects of getting this country ready for the tier 1 risk, the greatest risk in the entire risk assessment process. I think we should be sitting.
No, I don't. I think that what I took as a judgment was, firstly, that resources were needed to support the response to the real threat of disruption from a no-deal exit. And secondly, that I prioritised work that needed to be completed on capabilities that actually were used in the COVID situation, which included the pandemic flu bill. Those pieces of work could continue out with a board structure.
Now, there were a number of things that the board did see through to fruition. There was the drafting of a bill,
Yes.
which was the pandemic flu bill, the draft pandemic bill, which became the Coronavirus Act.
Yes.
Only in relation to the emergency regulations in England was that act used, wasn't it, when COVID struck, because Scotland, Wales and Northern Ireland all used earlier emanations of the Public Health Act, did they not?
I would have to check my records to see which piece of legislation. That would be an issue for the devolved administrations.
MEAG
Yes.
was put into place, the Moral Ethical Advisory Group, and that gave valuable assistance, of course, during the pandemic on the moral and ethical issues. One other piece of work that was done, was the board authorised, drafted and prepared and published something called the National Resilience Standard. That was a standard, a test, a check, if you like, for local resilience forums so that they knew to what standard their own preparedness plans had to be judged by.
Yes.
I put it to Ms Hammond, but I ought to put it to you because I think the National Resilience Standards for local resilience forums came, at least in part, from the Department of Health and Social Care. Did they not?
If I recall, it was a piece of work that was led by the Cabinet Office working in partnership with the department responsible for local government, but we will have supported that work.
All right. Are you aware that until the 14th of November 2019, just before the pandemic struck, the National Resilience Standards for local resilience forums across the entirety of England and Wales made no reference to any need to judge their work by reference to the plans that might be required for an influenza pandemic?
That would be a matter for the Cabinet Office and the Department for Housing and Local Government.
All right. The PIP board, or the PIP programme, what was that?
That was a programme that was led by my Director General, Clara Swinson. The responsibility of that body was to look at the delivery of the health and social care elements of pandemic preparedness. So it was a more internal health and social care focused programme.
And was there a long period during which it did not meet, or at least the board for the pandemic influenza preparedness programme did not meet?
As I recall, it also did not meet during the period of end 2018 to 2019.
Again, because of Operation Yellowhammer?
As I understand it, yes.
Do you agree that no pre-pandemic exercise in which your department was either an observer or a participant, and no outbreak report, and no DHSC policy or guidance paper considered the issue of the vulnerabilities and inequalities of parts of the community and how they might be affected by the plans that you were drawing up for a pandemic influenza?
No, I wouldn't agree with that statement. I think there was consideration taken for the impact of vulnerable people of a pandemic influenza.
Clinical vulnerability, Ms Reid. It was clinical vulnerability. It was obviously, in the event of a pandemic, the pandemic and our responses to the pandemic will have an impact clinically on those who are at greatest risk from the disease. was there any consideration of anything other than clinical vulnerability?
I believe that there were considerations of wider inequalities for those individuals who would potentially find it difficult to access health and social care systems. You mentioned earlier also the Moral and Ethical Committee that considered issues around concerns from different faith groups about the approach to vaccination and shielding. So there were areas where thinking about protected characteristics were a consideration in our planning and preparing. There was no systemic assessment of protected characteristics impacts, but individual work programmes were considering impacts on vulnerable people.
The work programmes to which I now understand you may be referring, was that the work done to ensure that if individuals want treatment, clinical treatment, steps needed to be taken to mitigate differential impact by ensuring that health communications will be available in a range of languages?
There was work undertaken to think about how we reach communities where English is not the first language. I would say that it is writ within the principles of how we deliver our work that we consider health inequalities at a national and local level. And so communications would in themselves think about people who may not be able to access information where English isn't their first language.
Ms. Reid, other than the obvious point that some people may be more clinically vulnerable to a pandemic, the only consideration in this whole 10-year period given to the position of members of ethnic minority groups or vulnerable sectors of society by way of your pandemic planning was making sure that health information would be available in a range of languages. Is that the sum of it?
I don't believe that to be true. We considered equality impact assessment as part of the 2011 strategy. We considered an impact assessment as part of the pandemic build preparedness that you mentioned earlier. In guidance that went to local resilience forums, they talked about people who would struggle to access mainstream healthcare, which included those who were homeless and disenfranchised. So there was work to do that. It wasn't systemic and systematic, I apologise, but there was work to consider vulnerable people.
The work that was done, and you've just referred to it, was a consideration. There was a paper called the Equality Duty paper, which came out around about the same time as the 2011 strategy. There was nothing thereafter, which considered the legal obligation imposed on the government generally under the Equality Act 2010, known as the Public Sector Equality Duty. Is that the duty to which you're referring?
Yes.
Right. That was a broad omnibus consideration of the power or the duties of the government under the Equality Act. Where was a single paper referring to what the impact would be on the particular parts of society to which I've made reference of either a pandemic or your planning?
There was no single piece of paper with that on it.
Right. And do you accept from me evidence from the government's own Equalities Hub and its director, Mr. Bell, who's given a witness statement to Milady, which says reasonable and proportionate searches have been conducted. I can confirm that this department was involved in no work related to the United Government's response to civil emergencies, including a pandemic. There was no contribution to the design or preparation of any policy response on behalf of the United Kingdom government in the event of a pandemic. Just no work was done on this topic at all, was it?
There was no overarching assessment of the impact of the pandemic preparedness strategy on inequalities since the publication of the strategy in 2011. Had there been a revision, we would have done that.
All right. Those are all my questions. Thank you. Lady, that concludes the evidence of Ms. Reid.
So no Rule 10.
Have there been any applications which permission has been denied, or no applications? There were applications, but permission has been denied.
Thank you very much. Thank you, Ms. Reid. Thank you for your help.
Thank you.
My lady, good morning. The next witness is Rosemary Gallagher, MBE. May she be sworn, please.
I swear by Almighty God
I swear by Almighty God
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Is it Miss or Mrs. Gallagher?
It's Mrs.
Thank you. Mrs. Gallagher, thank you very much for the assistance that you've so far given to the inquiry, and thank you for coming to give evidence today. Please keep your voice up, speak into the microphones so that the stenographer can hear you for the transcript, and if I ask you a question that isn't clear, please ask me to repeat it and I will. If you need a break before our usual time of breaking, which I think will be 1 o'clock today,
Or maybe 1:15, depending on how we
or
get.
maybe 1:15, thank you. Then please just say so. Is it correct, Mrs. Gallagher, that you are the professional lead for Infection Prevention and Control, or IPC, and Nursing Sustainability Lead at the Royal College of Nursing, a role that you have held since 2009?
Yes.
Thank you. In terms of your professional career to date, you were a senior nurse in infection control at Stoke Mandeville Hospital from 2002 to 2008. In 2009, you represented the Royal College of Nursing as a member of the Pandemic Influenza Clinical Operational Advisory Group dealing with the H1N1 swine flu pandemic. And from June to October of 2015, you assisted the World Health Organization on behalf of the RCN with the MERS outbreak in Saudi Arabia. Between 2014 and 2016, you led the RCN response to the Ebola viruses disease outbreak in West Africa. And in November 2018, you joined the Emergency Preparedness, Resilience and Response, EPRR, Clinical Reference Group of NHS England at the request of its director, Stephen Groves.
That's correct.
You have provided 2 witness statements. May we put up first, please, 177809. Can you confirm that that's your first witness statement, Mrs. Gallagher?
That's correct.
Thank you. And now 183414. Thank you. Is that the second statement that you've provided?
That's correct.
Thank you very much. My lady, could we have permission for those to be published? Thank you. We can take that down. I'm going to begin, please, by asking you to describe to us the role and function that you hold at the Royal College of Nursing.
So I'm a registered nurse.
Yes.
And I provide strategic leadership on behalf of the Royal College of Nursing on matters relating to infection prevention and control. I provide specialist infection prevention and control advice to the college, to our members and our stakeholder organisations that we work with. My role is a UK-wide role, and I'm one of a team of about 13 professional leads that work together to cover many areas of nursing practice.
Right. And it being a UK-wide role, how do you ensure a tailored approach to the particular needs of each of the devolved nations, for instance?
So the RCN has covers the 4 regions of the United Kingdom, and my role often involves both proactive and reactive work. With the proactive work, we engage with the 4 countries, the 4 regions of the Royal College of Nursing, and as far as possible with our relevant organisations in the countries as well. For reactive work, we would respond according to the need and what it was that I could support them with.
Thank you. Moving then to your role with the EPRR Clinical Reference Group, a role that, as we've established, you've held since November of 2019. Could you provide us with an overview of what that group does and in particular what your role is within that group?
I was asked to be on the group as a nurse,
yes.
Not specifically in relation to my experience with infection prevention and control, although that was thought to be advantageous in terms of some of the discussions that took place in the meetings, and I shared that role with a colleague who represented public health nursing. As a member of the EPRR, we were there to represent our discipline of nursing and to provide nursing input and advice onto the discussions that were on the agenda at that time.
Right, thank you. At paragraph 17 in your witness statement, you tell us that pandemic preparedness with the group focused only on influenza and was not a significant regular agenda item at meetings of the group, and that the need to consider other potential infections with pandemic potential was made public by the Chief Medical Officer for England in July of 2019. And this position was supported by the RCN due to the experience that it had gained through its planning to support Saudi Arabia with the MERS-CoV outbreak. You also say, Mrs. Gallagher, that additionally, Disease X was added as a new category to the World Health Organization's emergency priority list in 2019, but that the UK continued to focus on influenza, despite the experience of MERS in the Middle East and severe acute respiratory syndrome, SARS, and the potential for a new coronavirus to emerge. So the Chief Medical Officer had given advice in July 19. The World Health Organization had made Disease X, given it a place on the emergency priority list in the same year. And yet the group upon which you sat was giving pandemic influenza only a priority in its discussions, and even that wasn't a regular agenda item. Were you concerned about that?
The overarching pandemic planning did not feel as if it reached into the EPRR group, whose agenda focused on much more recent incidents and our response and our learning from those. So it was an ad hoc agenda item, but not a regular item, and I'm unsure exactly how the EPRR group fed directly into the governance systems for pandemic planning.
Did you personally have any concerns prior to January of 2020 that the focus within the group was too narrow, given as it only appeared to consider pandemic influenza?
The RCN had raised concerns regarding the opportunities for other organisms with pandemic potential that we needed to consider. If I recall the discussions, it was more of an agenda item rather than an opportunity to feedback. It was more feedback on where the pandemic planning was going.
The inquiry has heard an explanation or justification from those who were focused perhaps too narrowly on pandemic influenza, that in fact plans could be and should be adapted. So the fact that pandemic influenza led to a certain level of planning was able to be seized upon and used during the course of the COVID pandemic. Do you agree that clinical preparedness plans are capable of being adapted for different infectious diseases?
I believe that if you have the principles right in relation to pandemic planning, that you can use those as a platform to adapt as situations evolve. You cannot have a specific plan for every specific organism, but it's important that we get the foundation structures right.
Thank you. The inquiry has heard from Professor Dame Sally Davis, former Chief Medical Officer, and in her witness statement to the inquiry, she has said, "I have previously expressed the view that whilst the World Health Organization has said that the UK was well prepared for a pandemic, those preparations assumed a pandemic of influenza. This reflected a long-standing bias in our preparations in favour of influenza and diseases that had already occurred, with, we now know, an underestimation of the impact of novel and particularly zoonotic diseases." Do you agree with that?
I do.
Yeah. And in his evidence to this inquiry, Jeremy Hunt has said that in his view, there was a groupthink, that the United Kingdom knew that this stuff, as he described it, the best, and that we had no need to look further afield to other countries in order to try and learn from their experience. In particular, he said, I don't think people were really registering, particularly Korea, as a place that we could learn from. Did you observe this type of groupthink as described? Yes. And did you raise your concerns in relation to that with anybody or any organisation?
In response to the work that we did with Saudi Arabia, and also in relation to the work we did on Ebola, we raised significant concerns around the different needs, for example, for personal protective equipment that may differ from influenza. So the concerns that we raised came out of our experience supporting other incidents and were fed directly back to those involved.
Right. Well, I want to ask you about your personal involvement with incidents representing the Royal College of Nursing. In your witness statement, you tell us that the Royal College of Nursing was invited to be part of the Pandemic Influenza Clinical and Operation Advisory Group, or PICO. And that was as part of the response to the H1N1 swine flu in 2009. Tell us about your experience in that group, please.
So, as part of the pandemic response in 2009, the college was approached to provide representation to the PICO. It was a clinical subgroup that I understand provided advice to SAGE at the time. Other members of the PICO included other medical royal colleges and those with other relevant areas of expertise. We discussed situations or drafts of guidance that were being developed, and we met weekly. I shared that role with two colleagues within the Royal College of Nursing to ensure that we provided the correct level of representation. That included my colleague who led on health and safety, and the professional lead for community and primary care at that time, so we considered all care settings. I found the PICO an excellent group. It allowed for multi-professional discussion and scrutiny of proposed guidance. The end result of that discussion would be agreement on a specific position or to approve the guidance moving forward.
So you would describe this as an example of clinical stakeholder engagement working well?
Yes.
And what you tell us, Mrs. Gallagher, at paragraph 40 in your witness statement is that we were able to feed in our expertise and intelligence and represent the needs of the Royal College of Nurses membership to inform the development of clinical guidance and guidelines concerning the response to pandemic flu. And then you go on to say this was a very different experience to the approach taken by the United Kingdom government during the COVID-19 pandemic. How so?
My experience in the early stages for Module 1 is that the opportunities for engagement of stakeholders from my position from the Royal College of Nursing was extremely limited. So this was a very, it had the perception of a very hierarchical response. Given that it was a command and control situation, however, we had the experience of knowing that stakeholder engagement could be implemented and worked very well in previous pandemics.
Well, indeed, and Dame Deirdre Hine, in her review following the swine flu outbreak, at paragraph 6.60 in her report, says further engagement is needed between health departments, professional bodies and employers to further develop clinical advice and provide support to staff during a pandemic. Is it your experience, Mrs. Gallagher, that that lesson was or wasn't carried forward and incorporated into preparedness planning for the COVID-19 outbreak?
So the Royal College wasn't specifically involved in pandemic planning. Our experience does not reflect stakeholder engagement, and I would just like to add that it's not just the development of clinical guidance or guidelines that requires stakeholders to be involved. Nursing is the largest part of the healthcare worker workforce, and actually we have a key role in implementing guidance and guidelines, so it's absolutely vital that we are around the table to be able to identify opportunities or risks to that proposed guidance.
But that didn't happen.
No.
When didn't it happen? I got a feeling that you were moving on to when the pandemic really was acknowledged as having hit. So in other words, a response rather than...
So I was referring to the very early days up until the middle of January, because I'm aware Module 1 only covers that short time period.
All right, but in relation to pandemic planning,
yes,
there was a lack of engagement with the Royal College of Nursing.
That's correct, yes.
You tell us in your witness statement about playing a clinical advisory role during the Ebola virus's disease outbreak.
Yes.
Can you tell us what that involved, please?
So the Ebola epidemic in West Africa was extremely challenging, and a request was made for UK nurses to go out and support the delivery and action in West Africa. This request was, from a nursing perspective, was led by Public Health England.
Yes.
And I was asked to provide professional support to the nurses that were leading that response. This was really about where the RCN could add value, as somebody put it, at a time when everybody was running towards the fire. We are able to sit back and reflect on what is needed from a professional and regulatory and indemnity perspective, and to support those nurses who may be interested in going to West Africa under those conditions, to really understand what it is they need to do and the level of competency and capability that is needed to do that sort of role.
All right. And was it possible, in your experience, for lessons to be learned by the government in pandemic planning from the time of the Ebola virus's outbreak until COVID-19 hit at the beginning of January 2020?
Yes, one of the most useful lessons for us, unfortunately, occurred when a healthcare worker in Spain acquired Ebola virus disease as a result of caring for a patient in a hospital in Madrid. Now, that healthcare worker was not involved in providing direct care. There were many, many lessons that were identified as a result of a European Nursing Summit through our relationship with the European Federation of Nurses, to identify lessons around how we can best protect healthcare workers from what we call high consequence infectious diseases now, such as Ebola. Now, we were not preparing for a pandemic of Ebola. This was very much a local situation, but it highlighted significant lessons around how infection control policies were written and the need to engage with clinical staff. It identified lessons around not just what type of personal protective equipment was needed, but how we support staff to be educated on how to put these on and take these off safely. And it also highlighted many lessons around confidence and communication and transparency that was needed by the healthcare workers.
I wanted to ask you about the culture of transparency and learning. What do you say in relation to that should have been carried forwards and perhaps wasn't?
We fed the lessons back from the experience of that meeting in Madrid directly. At the time, I was part of a Department of Health communications group that actually worked very well, again, with other stakeholders around the table, where we were able to feed in both intelligence from within the UK around how some vulnerable groups were feeling stigmatised as cases started to be imported into the United Kingdom, but on this occasion, more importantly, about the lessons we learnt from Madrid. So that worked very well. However, I have no knowledge of what happened with those recommendations and that report after it was delivered.
All right, thank you. Moving forward to MERS-CoV, could you outline your role, please, during the outbreak in the Middle East in 2015?
Yes, a request came in to Public Health England through the global through GORN, which was a global network requesting support in Saudi Arabia, particularly in relation to the spread of MERS-CoV within hospitals. There was real concern that healthcare workers were becoming infected with MERS, and MERS did have some sustained transmission between people at that time. We were asked to effectively identify nurses that would be willing to go to Saudi Arabia to support education and training on infection prevention and control. We undertook an assessment of the situation and were actually very concerned about potentially just going out to seek nurses to respond to this. And we asked if it would be possible to undertake an assessment in person so that we could identify whether it was appropriate for nurses to go there, number one, but also to identify what risks might be present both culturally, clinically, the holistic view. And it was on that basis that we were asked to visit, when I say we, myself and a colleague in Public Health England, to visit and undertake that assessment. And the subsequent ask, given our expertise, was then to look more widely at potential transmission of MERS-CoV and how infection prevention and control might support that.
Right, and you tell us at paragraph 36 in your witness statement that you believe, in your extensive experience of that outbreak, significant lessons should have been learned from the experience with MERS-CoV. For example, the Gulf Cooperation Council's IPC guidance specifically addressed the airborne spread of MERS-CoV and the requirement for the use of RPE.
Yes, that's correct.
And you go on to say in the following paragraph, the COVID-19 pandemic has shown that there was too much of a focus on preparing for a flu pandemic and not enough consideration was given to how such plans would need to be adapted to deal with a respiratory infection pandemic, where the primary mode of transmission was not necessarily via traditional droplet transmission. And that airborne transmission needed to be properly factored into the IPC guidance concerning the level of PPE required for healthcare workers exposed to patients with COVID-19.
That's correct. We had the experience of MERS-CoV in Saudi Arabia, and we additionally had the South Korean experience as well, both of which showed that transmission within healthcare facilities was entirely possible in addition to community spread of infection.
What is the difference between PPE and RPE?
So RPE stands for respiratory protective equipment, and it is one form of personal protective equipment. Personal protective equipment is a broad term that in healthcare would cover items such as gloves, aprons, respiratory protective equipment, for example. PPE is designed to protect the wearer from a hazard. So in the case of a pandemic of whatever cause, that would be the infectious agent or the biological hazard that is present at that moment in time.
Are there lessons that you believe could have been learned from countries dealing with MERS-CoV regarding the stockpiling and use of RPE?
Yes. When you're, in my view, if you are planning for a pandemic, we need to consider all eventualities. So we need to consider both potentially the use of surgical masks, but they are not personal protective equipment, and consider the need for respiratory protective equipment for an infection that is spread through the respiratory route predominantly, not exclusively, but predominantly. It's my view that there was inadequate consideration given to not just the use of respiratory protective equipment for a prolonged period of time, but exactly which elements of the health and care system would need to use respiratory protective equipment if we had widespread infection.
Right. So not just for hospital settings?
No, the NHS is more than buildings. So the NHS considers, the NHS has hospitals and healthcare facilities, but also community teams, community nurses, district nurses, GP practice nurses, for example, all make up part of the NHS. So NHS care goes beyond hospitals.
All right, thank you. I want to ask you now about the level of engagement that the RCN had in the preparation of exercise Cygnus, which we know began to be prepared in 2014, but in fact didn't take place until 2016. Was the RCN involved in any sense in either the preparation or the carrying out of that exercise?
Not to the best of my knowledge.
Do you know whether or not the RCN was invited to be involved in the preparation or carrying out of the exercise?
No.
Corporate memory. You tell us in paragraph 34 of your witness statement that you have concerns about the loss of corporate memory.
Yes.
You say there was a palpable change in culture in the years immediately preceding the COVID-19 pandemic, brought about by the successive administrations. This seemed to manifest in an attitude where engagement with stakeholder organisations seemed to be less of a priority. Can you expand upon that, please? What did you mean by a palpable change in culture?
So as I've described, our experience supporting the incidents of MERS and Ebola were very positive experiences in terms of the engagement and the value that professional nursing was held in so far as we could support that. At the time, around 2017, we were also part of an antimicrobial resistance programme board that was managed by Public Health England, that again had a variety of stakeholders, including the RCGP, the Royal Pharmaceutical Society, around the table. Once that was disestablished, about a year later, stakeholder engagement was significantly reduced and really remained that way until the pre-pandemic period.
All right, and just taking that into account and moving back for a moment to exercise Cygnus, do you believe it was a mistake for the Royal College of Nursing not to be involved in that exercise?
Yes, but I would go further and say it was a mistake not to involve other professional organisations alongside ourselves as well.
Thank you. May we put up, please, a paragraph of the report that's been provided to the inquiry by Dr. Klaas Kerschel. Thank you. It's at 205178, and we're looking at paragraph 112. I want to seek your opinion on this paragraph, please, Mrs. Gallagher. There were also ongoing concerns about Public Health England's ability to act as an independent advocate for public health from within the Department of Health, from 2018, the Department of Health and Social Care. In 2014, the British Medical Association warned that the requirement to adhere to civil service rules and regulations is having an impact on PHE's staff's ability to do their work. Particular concerns have been raised about the ability to publicly discuss or criticise public health policies. In surveys, local authorities noted that Public Health England could do more to acknowledge the pressures and constraints facing local authorities in its work with them and be more vocal around issues such as welfare reform and austerity and what this means for the health of our nation. A later witness seminar also highlighted that the increasingly rapid turnaround of civil servants across government departments had created a lack of specialist interlocutors and understanding in Whitehall. In your view, Mrs. Gallagher, did Public Health England become less able to effectively advocate for public health and public health budgets in the period preceding January 2020? Are you able to give us your opinion on that?
What I can say is that the Royal College of Nursing was very concerned around the reduced funding for Public Health England and the impact that that was having on local authorities and local health protection teams to support population health initiatives in that time. From my perspective, obviously from an infection prevention and control position, the conversations continued in terms of business as usual, but not necessarily in relation to how we could move work forward to increase population health and respond to incidents at pace.
All right, thank you. We can take that down now. Finally, on the issue of stakeholder engagement, before we leave this topic, please could we display INQ 148405, and it's page 5, paragraph 15 of Professor Kevin Fenton's witness statement, he being the President of the Faculty of Public Health. If we could look over the page, please. In fact, let's look at paragraph 15 on page 5. Thank you. Could we highlight that, please? Generalist specialists in public health, particularly those working in health protection at regional and local levels, have been underrepresented in the development of national pandemic policy, strategy and guidance. And there is opportunity for this to be addressed in the future through the UKHSA-hosted Centre for Pandemic Preparedness. There was a significant missed opportunity for broader engagement in planning across local resilience forums and local health resilience partnerships, which require closer working and mainstreaming of planning, training and exercising of pandemic response arrangements. From your viewpoint, working within the Royal College of Nursing, do you agree with those sentiments?
I do.
Thank you very much. We can take that down, please. By early 2019, is it your view, Mrs. Gallagher, that there were sufficient structures in place for raising, escalating and addressing concerns on behalf of frontline staff amongst the UK preparedness bodies?
I don't think I can answer that question because we weren't specifically involved in preparedness.
All right. So because of your lack of involvement at all, it's not possible for you to comment on that question.
No, could you repeat the question again for me, please?
Yeah, it was whether or not you considered that there were sufficient structures in place for escalating and addressing concerns on behalf of your frontline staff with the United Kingdom preparedness bodies.
No, that wasn't in place. We weren't able to contribute to that.
All right. Well, and indeed, as you've already said, there was a complete lack of engagement with the Royal College of Nursing in terms of preparedness. So there was no option or potential for raising those issues on behalf of your frontline staff. You tell us in your witness statement that in terms of your role at the Royal College of Nursing, and indeed you've confirmed this morning, that it was as part of a UK-wide organisation. Did you have any concerns in relation to how EPRR had been dealt with in any of the devolved nations in terms of the frontline staff there?
No. I only attended the EPRR group, which was based in England.
Yes.
However, we did, if it was available at the time, take intelligence or feedback from our members in relation to what was relevant to feed into the EPRR group. To the best of my knowledge, the agenda items that would discuss the lessons there would have been learnt, would have been shared with the 4 countries, but I wasn't party to those discussions.
All right. I want to come on to discuss workforce resilience issues, which are crucial to a pandemic. Mm-hmm. What is the relationship, Mrs. Gallagher, between the resilience of health systems and the resilience of the workforce within healthcare and social care?
So the resilience of the health and care workforce is absolutely essential in order to be able to deliver healthcare services that meet the public's needs. We know that we went into the pandemic with a significant shortage, about 50,000 nurses short before we went into the pandemic. And therefore, that immediately put us at risk when we needed to surge capacity to support patients who were infected either at home or in hospitals.
Had the RCN in your view, consistently highlighted over a number of years the absence of effective workforce planning for nursing?
They had.
And what was the reaction of the government to that being highlighted?
The RCN has campaigned and lobbied for many, many years around what we now call safe staffing for effective care. The RCN has participated in significant research with our European counterparts around the impact of insufficient numbers of registered nurses, for example, on patient care and the implications for patient safety. The RCN has responded to all the consultations and also comprehensive spending reviews highlighting the importance of investment in the nursing workforce.
Has this been handled differently across the different nations? What I'm coming to is asking you about the fact that the Welsh Government have implemented the Nurse Staffing Levels Wales Act, which was passed in March of 2016. And does that mean that health boards and NHS trusts in Wales must have regard to the importance of providing appropriate numbers of nurses in all settings?
That's correct.
And in Scotland, the Health and Care Staffing Scotland Act of 2019 has been passed, setting out requirements for safe staffing across both health and care services, but the implementation of that, in fact, was delayed due to COVID-19.
That's correct.
So is that still pending, as far as you're aware?
As far as I'm aware, but I'm not leading that piece of work, so...
All right. And you also tell us in your witness statement that in Northern Ireland, members took industrial action in December 2019 and January 2020 over safe staffing and pay.
Yes, they did.
So just immediately going into the pandemic?
Yes.
All right. So does this still remain a concern of high priority for the RCN across the four nations?
Yes, absolutely. I mean, there are clearly differences across the UK in terms of how workforce and the need for an appropriate workforce level is implemented across the UK.
Thank you. I'd like to display, please, the witness statement of Jeremy Hunt, please, just to underline this point. Page 15, paragraph 66. Could we highlight this, please? As I have written elsewhere, one of the things I learned as my time as Health Secretary and wish I had understood better at the outset was the importance of workforce planning. This is not something I implemented while Secretary of State because it took me some time to appreciate the full picture. I was also not advised to place more emphasis on this because the NHS had a long-standing habit of relying on immigration to fill any gaps. However, with a 2 million shortage of doctors globally, according to the World Health Organization, this was not a sustainable position in the long term. Now, the former Secretary of State for Health and Social Care doesn't mention nursing there. No. He uses the shortage of doctors as an example. But would you say, Mrs. Gallagher, that the issue was just as important in relation to nursing and workforce planning?
Absolutely. We know we have a global shortage of nurses, as identified in the Triple Impact report. So this is a global problem, and the reliance on overseas nurses is a real cause of concern for the Royal College of Nursing.
Thank you.
I think, Ms Blackwell, we are going to have to pause there because we've got a strange noise that I know may need fixing. I don't know if you're conscious of it.
I can't hear it, I'm afraid.
Initially, I thought it was thunder, but...
Right.
Forgive us. You're going to have to come back, I think, this afternoon, Mrs Gallagher. I hope it's not too inconvenient for you. I shall return at, I'm being told, 1:45.
Fingers crossed. Thank you.
So, for example, we know we have far fewer health visitors at the moment that support mothers and also support young children, and that is vital in terms of local communities. In terms of operational management of the pandemic, that at a local or regional level would be supported by the health protection teams. And they are absolutely vital in having good relationships, collaborative relationships with provider organisations such as NHS trusts, but also in supporting care homes. Now, health protection teams came under Public Health England, they're now under the UK HSA, and their roles have continued, but with the changes in the landscape, those roles and relationships have changed over time. So it's a bit of both, if you like.
All right, thank you. Professor Philip Banfield from the British Medical Association has provided a witness statement to the inquiry in which he says that reforms to the public health system, in England in particular, led to a fragmented system, and that the 2012 Health and Social Care Act fractured in many places the links between public health specialists and NHS colleagues, which in turn impacted upon pandemic response. Do you agree with that?
I do.
All right. What role does community infection prevention and control have to play in pandemic planning and emergency response?
So the role of community infection control teams has changed over time. When I was in clinical practice, we provided support from the acute trust to our community partners and provided them with an infection control service. But in other areas, they have dedicated infection control teams. So there is variation across the system on how advice is provided. We know that when the Lansley reforms, the changes to the NHS, the Health and Social Care Act was implemented, that we lost many community infection control teams as staff moved under the umbrella of local authorities away from their original employers. And that gap, if you like, placed increased pressure on health protection teams, but also had an effect on local relationships and resilience locally.
May we put up, please, the statement of Professor Kevin Fenton at paragraph 11, pages 3 to 4, and highlight that, please. Thank you. Here he says, health protection teams which moved from the Health Protection Agency to Public Health England saw successive reductions in funding and capacity over the pre-pandemic years and a lack of investment in regional emergency preparedness, response and resilience teams. A direct result of these changes was a reduction in the amount of professional exposure that the public health specialist generalist workforce had to health protection duties and continuing professional development outside of PHE. There was also a reduction in the exposure that NHS staff in general had to important public health issues associated with health protection. Thank you, especially in community settings. This is likely to have contributed to a poor understanding of the role of the wider public health agenda around pandemic preparedness, and more specifically, the role of local authority public health teams and wider system partners in pandemic preparedness and response. Community infection prevention and control is a key element of pandemic planning and local health protection more generally, but guidance is unclear on commissioning responsibilities, funding streams, and standards for high-performing local integrated services. It is largely understood that provision for community IPC was a significant casualty of the 2012 reforms, and the faculty considers the creation of integrated care systems with local authority directors of public health and the UK HSA as key partners an opportunity to rectify current problems. The use of contain outbreak management funding during the pandemic is to temporarily increase IPC capacity in many systems provides proof of concept of what can be achieved through concerted effort and funding enhancements. Do you agree with Professor Fenton's suggestion that guidance on commissioning responsibilities, funding streams and standards for high-performing local integrated services is unclear?
From my experience, yes.
And do you also consider that the provision for community IPC was a significant casualty of the reforms, I think, as you've just referred to?
Yes, I do.
All right. And towards the end of that paragraph, Professor Fenton suggests that the use of the COMF during the pandemic to temporarily increase IPC capacity demonstrates the concept of what can be achieved. Do you agree with him in that regard?
I do. In order to sustain the benefits that have been achieved through this, however, I would also focus on a need for standardised training as a foundation, a cornerstone for health protection teams, because there is no standardised education currently for health protection practitioners.
And how would that be best achieved?
There are a number of ways in which education can be commissioned and delivered. For me, the starting point would be to identify the needs of health protection practitioners who are not all nurses at all. Many do not have a nursing background. And to support them to identify what is needed in order for them to deliver their role in practice.
Thank you.
Just before you go on, can you explain? I appreciate it's not your expression, Mrs. Gallagher. Specialist generalist sounds a bit contradictory to me.
Sorry, that's me.
Is it? Oh no, I think it's in this report as well.
Oh, I see.
What is a specialist generalist?
I'm not quite sure, actually.
Right.
We'll provide a definition
Yes.
for my lady.
Thank you. I hope it makes sense. At the moment, it doesn't.
We can take that
I know
down.
what it means, but I wouldn't like to say.
In terms of the problems created in health, public health provision, the inquiry has heard from Professors Marmot and Bamborough that those difficulties that arose, those highlighting of inequalities that developed, hit certain areas of the country hardest and hit people who were suffering from particular inequalities even harder, living in those areas. Is that something that you recognise? And if so, is the difficulty with inequalities, and that caused by funding or lack of workforce planning or some of the issues that we've looked at, is that something that the Royal College of Nursing was alive to prior to the onset of the pandemic?
Certainly in relation to the impact of the pandemic, we're very aware of the effect of inequalities both on our nursing workforce but also on those that required care or were most affected by the pandemic. The second part of your question in relation to workforce.
Yes.
Could you just repeat that for me,
Yeah.
please?
What I'm asking is whether or not the fact that inequalities hit in particular areas, as Professors Marmot and Bamborough have told the inquiry, and whether or not that was exacerbated by either workforce issues or public health funding cuts or a combination of both. And if that is something which the Royal College of Nursing recognises, was that something that was apparent prior to the onset of the pandemic in 2020?
Certainly, the Royal College was very aware of the impact of inequalities from a public health perspective, and then obviously whatever impacts on our public health ultimately affects our hospitals and the demand for hospital services. So the two are very closely related. The issue of black and ethnic minority staff in terms of their experience in the workforce is well documented by the Royal College of Nursing.
And is that something which to which the Royal College of Nursing was alive prior to the pandemic?
Yes,
Onset of the pandemic.
I would, yes.
All right. Moving on to social care, please. You describe in your statement at paragraph 48 that there was not a whole systems approach to pandemic planning, particularly with regard to social care. And you say that from your perspective, this was evident at the start of the pandemic during efforts to rapidly scale up acute capacity when some community staff were being redeployed into the acute sector without sufficient thought being given to the services that needed to continue in the community. For example, and this is an example that you give in your statement, the Royal College of Nursing heard reports that community nursing staff were being asked to go and work in hospitals when community services needed to be augmented at the same time to ensure essential services such as child protection and end-of-care life could continue. You identified this as a problem. Was this a problem that had persisted prior to the pandemic, or was this something that came to light only when the pandemic hit and the staff, as you say, were being pulled from hospitals into the care sector and back again and vice versa?
Certainly you would expect to need to move staff in a case of need, in the case of a national incident. The pandemic highlighted really the impact of doing such actions, and there was real concern regarding how we would maintain care for our patients in the community. And we have many more patients in community settings than we do in hospital settings, for example. The RCN has raised concerns over a number of years around a reduction in the community nursing workforce and the implications for that, not just in terms of community care, but the knock-on effect of care in hospitals.
Right. As far as you are aware, was there any planning in terms of the movement of staff from hospitals into adult social care and workforce planning in any of the pandemic planning that was undertaken?
As I recall, as we took part in Operation Pika around 2018, the need to consider the movement of staff and the different demands in different care sectors at different times was on that agenda. To the best of my memory, I don't recall in-depth discussions on what the real impact of that might mean, particularly from a nursing perspective.
In your view, was there adequate operational guidance in place for managing a pandemic within the social care sector prior to COVID-19 hitting?
I'm not aware of any, but we weren't involved in the pandemic.
Yes, of course. Certainly none was brought to the attention of the RCN, nor was there any invitation given to the RCN to involve itself in any such guidance being prepared. All right. I'd like to ask you now, please, about the value of healthcare-acquired infection operational guidance, which you deal with at paragraph 53 in your witness statement. Now, there was the publication in 2012 by the Health Protection Agency of certain guidance, and you recall that the guidance was updated in 2016, I think, as an internal document, but that update wasn't published. Is that right?
Yes, that's a verbal report that I had. I've not seen the 2016 updated guidance.
Right. You say in your witness statement that the fact that this operational guidance wasn't published, that's the 2016 update, I think, meant that NHS teams, as well as care homes and community settings, didn't have up-to-date information on the roles and responsibilities of health protection teams, and that would have impacted directly on local, regional and national incidents, including responding to HCIDs such as COVID-19.
Yes, as I recall, the operational guidance was a recommendation that came out of the Stoke Mandeville report in 2016, 2006, apologies, where there was criticism around the role of the Health Protection Agency local team at that time and how they intervened to support the NHS trusts. The guidance is around roles and responsibilities, and relationships between health protection teams, acute trust and community providers is really important for dealing with local or regional issues, and therefore when it comes to a national incident is absolutely essential. The 2012 guidance focuses on healthcare acquired infection because Stoke Mandeville was predominantly around Clostridium difficile, a healthcare acquired infection. However, for me, this represents good governance and essentially having your house in order to have up-to-date operational guidance in place that can be referred to and is already in place.
Has the RCN been vocal in expressing its concern about a lack of guidance in this area?
I don't believe we've written anything formally, but it's certainly questions have been asked over the years since it was developed and at a time when it would have been reasonable to update it.
Yeah. One of the aspects that you bring to the forefront in your witness statement is the concern that has been regularly raised by the RCN at national fora, including the Care Quality Commission's stakeholder group for non-hospital organisations, that the CQC had not delivered on its regulatory responsibilities in relation to IPC to the extent of ensuring effective systems. Is that something which has regularly been raised by the RCN over the years?
So when I attended the CQC meetings on behalf of the Royal College of Nursing, I did raise this at those meetings, and I also took the opportunity, I can't recall which meeting specifically, but to raise this as part of concerted efforts to support the reduction in healthcare associated infections that didn't just focus on hospitals.
Right, and in particular, I think one of the concerns of the RCN was that a focused inspection was requested of the CQC in adult social care and to strengthen non-hospital-based IPC provisions. You say in your witness statement that despite that, the RCN is not aware of consideration being given to providers such as care homes being assessed in pandemic planning with regard to meeting the fundamental requirements of the Code of Practice or their ability to escalate issues if required. Is that right?
That's correct. The theory behind our ask is that if care homes are well prepared for business as usual, then when it comes to an incident, they are much better prepared to respond and consider how they will manage should that occur.
Was social care non-compliance something that you'd raised with the Department of Health and Social Care before 2020?
Non-compliance with regard to the Code of Practice?
Yes.
Do you mean? We raised concerns around the level of compliance, I would say, rather than non-compliance with the Code of Practice, which every provider of health and care has to meet in a proportionate way to their role. So there is a different expectation for care homes than there is, for example, to a large acute hospital. The essential expectations around having good policies and procedures and education in place would be fundamental to their response in a pandemic.
Right, thank you. We've touched upon PPE and RPE. Mm-hmm. And you tell us in your witness statement that as far as the RCN is concerned, there was a lack of or insufficient stockpiling of RPE that was needed. That's also a reference, is it not, to FFP3 face masks, which I think you've already described to us, the critical nature of those. You say that without a sufficient stockpile of that equipment, not only for hospital settings, but also for community nursing. Nursing staff are putting their own lives and the lives of their families and patients at risk. But in addition to the availability of such PPE, is it also necessary for those who are going to be utilising it to know how to fit it properly? And that involves staff training in fit testing. From an RCN perspective, is there, or indeed was there, at the onset of the pandemic, sufficient capability within staff who might need that PPE to be able to fit it properly? Had the training been in force and in place?
If I might go back a little step,
Certainly.
briefly, the failure to consider a pathogen that had pandemic potential, that would require the extended use of respiratory protective equipment was not duly considered. And it is my view that that had an effect on how large the stockpile was of respiratory protective equipment as opposed to face masks. If you take that to the next degree, then I would have expected consideration of the need to cascade fit testing to be in place as part of pandemic preparedness. When a pandemic or an incident first starts, it's absolutely critical that we also take a precautionary approach to what it is we are dealing with until the science tells us otherwise, and that would also have implications for how much respiratory protective equipment we would need. It's clear now that those systems for escalating fit testing and also the system for having standardised respiratory protective equipment was not in place. And by that, I mean the demand for respiratory protective equipment resulted in many different types of masks being available. And masks fit people differently. So whilst your face may fit one type of mask, it may not fit the other. So this then necessitated multiple attempts or multiple requirements to fit test staff on numerous occasions because of the numerous types of masks that were required. So I don't believe that the system was well set up to consider this as part of pandemic planning.
All right. So just to summarise your evidence, a lack of foresight in terms of the requirement for RPE, a lack of stockpiling for RPE, and then a lack of fit testing for the various RPE facilities.
Yes, or having systems in place to cascade fit testing. You can, for example, introduce a train-the-trainer system where you can cascade to staff. Most trusts would not routinely, well, I can't think of any trust actually, that would routinely educate or train all its staff to be fit tested all the time in RPE. However, we did learn from H1N1 and Ebola that there would be a need to expand and escalate fit testing and the use of RPE as part of those experiences.
In your witness statement, you discuss framing vulnerability as a clinical category in pandemic plans and guidance. In your view, were structural health inequalities factored into the government's pandemic planning?
No, I don't believe so.
And why do you say that?
So the structural health inequalities that I would consider of key importance to take into account would have included inequalities within the healthcare workforce, as well as the vulnerabilities and inequalities experienced by our population. And that has undoubtedly changed since the last pandemic.
How has that changed?
So we know that our levels of non-communicable diseases have increased. So diseases such as diabetes, obesity, for example, those have really escalated since the 2009 pandemic. Therefore, that there have been shifts in our populations that we would need to keep considering as part of our pandemic planning.
frontline workforce and planning for minority ethnic members of the workforce. Paragraph 63 of your report, you say that in its written submission to the Treasury Comprehensive Spending Review in September 2020, the Royal College of Nursing highlighted the overrepresentation of BAME staff at bands 4 to 6, which represent those professionals providing care on the front line, warning that they may be at increased risk of exposure to the viral load of COVID-19. And you also highlighted the fact that as the pay bands increase, data shows larger increases in the number of white staff at each pay grade compared to the increase in ethnic minority staff. Was the risk of a disproportionate impact on minority ethnic staff mitigated against within pandemic planning as far as the Royal College of Nursing is concerned?
In my opinion, no, but as I've stated before, we weren't involved in pandemic planning.
But you haven't seen anything or had anything brought to your attention in your position to indicate that it was so considered?
Not that I recall. The language used in most strategic documents tends to refer to at-risk groups.
Yes.
Or, as you've said, other clinical vulnerabilities linked to medical conditions, but not inequalities as described by Professor Marmot, for example.
Thank you. And finally, Mrs. Gallagher, turning to lessons learned for future pandemics. You've mentioned stakeholder engagement earlier in your evidence this morning. What do you say is missing, and what needs to be done in order to better ensure a level of preparedness, certainly so far as your organisation is concerned, with stakeholder engagement going forwards?
I would say that we need to revisit what we think stakeholder engagement means. There may be assumptions that stakeholder engagement could be something as simple as sending out a draft document to review and comment on. But the view of the Royal College of Nursing is that meaningful stakeholder engagement would entail involvement at the beginning rather than being a recipient at the end of a long process. We would also consider stakeholder engagement to be absolutely vital to allow us to really consider the impact of what we have learnt now in terms of vulnerabilities. So, for example, by engaging with other Royal Colleges or other organisations, which has been such a valuable lesson for us during the pandemic. So, for example, the inclusion of organisations such as the British Occupational Hygiene Society or speech and language therapists or others that can bring a combined view together with ours on how we operationalise or manage specific incidents or view guidance.
Thank you. And finally, is there any recommendation that you would like to bring to the attention of the inquiry so far as transparency is concerned?
Transparency is absolutely vital to support communication. In my experience, I have found that healthcare professionals and the general public are very understanding that guidance and advice changes as an incident or a pandemic evolves, and they are very forgiving of changes in guidance and advice, but they need to understand why. So we are able to bring people with us if we can do that, and bringing the public and our healthcare workers with us at a time of a national crisis is absolutely vital.
So transparency and information provision.
Yes.
Yeah, thank you. My lady, those are all the questions that I have. You have provisionally provided permission for COVID bereaved Families for Justice to ask a specific question around a meeting of the chief nursing officers back in 2014, according to the sheet that I have. May they ask those questions now, please?
They may.
Thank you.
Ms Munro.
Thank you, my lady. Good afternoon, Mrs. Gallagher.
Good afternoon.
In your witness statement at paragraph 29, I should have said, my name's Alison Munro and ask
Nice to
questions on
meet you.
behalf of bereaved, COVID bereaved families for justice. In your statement at paragraph 29, we don't need to bring it up, you make reference to a meeting on the 22nd of October 2014 between the Chief Nursing Officer and regional CNO nursing teams. It's a meeting you yourself did not attend, but you say that from discussions that flowed from that meeting, there were concerns about whether or not the voices of nurses were being heard, and that issue of stakeholder engagement that you've spoken about at length this afternoon and earlier this morning. Can you assist us, please? Were there wider concerns about the engagement with the Chief Nursing Officer and the RCN? And did you see any improvements following on from that meeting in 2014?
The feedback I had as a result of that meeting, which I wasn't present at, was that the information that was provided, and this was in relation to the Ebola outbreak, had been positively received, and that there was that it had been taken on board around the need for nursing to be engaged in this response. I don't recall any issues in relation to relationships. There were good professional working relationships at that time, but clearly because this was in response to an incident that was occurring at a moment in time, the meeting was called at quite short notice, to the best of my memory.
You said there were good working relationships. You've been referred to paragraph 34 of your statement again earlier before the lunch and adjournment, where you speak about certain significant changes that happened in the healthcare system and the culture around about the time of 2018 to 2019. Now, with regards to the Chief Nursing Officer, Dame Ruth May succeeded Jane Cummings in January of 2019. To what extent did that change have an impact, if at all, on the pan-professional working and communications between the CNO and the RCN?
To the best of my knowledge, there was no detrimental effect at all when Dame Ruth May took over her position of CNO. Most of my experience before that had been to work to the Deputy Chief Nurse in Public Health England, who then held a strategic relationship with the Chief Nursing Officers team in the NHS. From my perspective, the change in CNO leadership didn't cause any issues at all.
Thank you very much. Thank you, my lady.
Thank you, Ms. Munro.
That concludes Mrs. Gallagher.
Thank you very much indeed for your help, Mrs. Gallagher.
Thank you.
My lady, may I please call Professor Dame Jenny Harries? Would you take the oath, please?
I do solemnly, sincerely and truly declare and affirm that the evidence I shall give shall be the truth, the whole truth, and nothing but the truth.
May I begin by thanking you for the assistance that you've so far given to the inquiry. You have produced an extensive witness statement. May we have it on this screen, please? It's 148429. Can you confirm that that's your witness statement, please, Dame Jenny? Thank you. We can take that down. And we have also had 2 witness statements from Professor Isabel Oliver, who is the Interim Chief Scientific Officer. The first statement on the 17th of May 2023, which is at 194054, and then a supplementary statement on the 12th of June of 2023 at 212902. And may we have permission, please, to publish Dame Jenny's witness statement and the second of Professor Isabel Oliver's statements, please, today. I can inform my lady that the first witness statement of Professor Oliver will be published at a slightly later date.
Thank you.
Thank you. Please keep your voice up during questions, Dame Jenny. If I ask anything that you don't understand, just ask me to repeat it and I will. And I'm going to begin by taking you through your professional qualifications and previous roles and relevant experience so far as it is relevant to our inquiry. So you are now Chief Executive of the United Kingdom Health Security Agency since its formation in April of 2021 and Head of the NHS Test and Trace since May of 2021. Prior to joining the UK HSA, were the Deputy Chief Medical Officer for England between 2019 and 2021. And prior to that, you were the Regional Director of the South of England at Public Health England from 2013 to 2019. And prior to that, you were the Interim Deputy National Medical Director between 2016 and 2017. You have also worked as a Director of Public Health. You are a medical physician with specialist training in public health medicine. You have formal qualifications in medicine and pharmacology, a master's degree in public health, and also one in business administration. You have a postgraduate diploma in health economics evaluation and a postgraduate certificate in strategic planning and commissioning. You are a Fellow of the Chartered Management Institute, a Visiting Professor of Public Health at the University of Chester, and Honorary Fellow of both the Faculty of Occupational Medicine and the Royal College of Paediatrics and Child Health. You are a member of the Joint Committee on Vaccination and Immunisation, National Advisory Committee on the NHS Constitution, NHS England Clinical Priorities Advisory Group, and Women's Health Task Force. And in particular, you were the National Programme Director for Ebola screening and the UK Returning Workers Programme in 2014 to 2016. And you were the SRO of the subsequent development of the High Consequence Infectious Disease Programme. And prior to the COVID-19 pandemic, you contributed to various significant health protection incidents, including Zika in 2016, the Hurricane Irma response in 2017, the Novichok poisonings in 2018, and the first cases of monkeypox in the United Kingdom in 2018. During the COVID pandemic, you chaired the SAGE Social Care Working Group, led clinical work on the initial shielding programme, and acted for SRO for coordination of the subsequent enhanced protection programme for those who remain more clinically vulnerable to serious outcomes from COVID-19.
Broadly, yes. Can I just clarify a couple of points? So the roles where you said I started with membership of the JCVI, those are previous roles, they're not current, and that's important, I think. The most important qualification, which you probably didn't read out, was a fellowship of the Faculty of Public Health. That's probably the most important one for now. And then I would also just like to flag, I am, just for clarity, I am a Welsh resident, and I realise there might be conversations around UK countries, and I trained in Wales, and to flag actually that I've spent more of my time professionally working in local, as you said, as a Director of Public Health and in regions than I have nationally. So where that is relevant, I'm assuming it will be okay for me to add that commentary.
Thank you. Let's deal first, please, with the background and history of public health bodies in England, starting with the Health Protection Agency. which was established in April of 2003. And to help put things in historical context, is it right that the HPA was the public health body in operation in England during the SARS outbreak in late 2002? But that outbreak, of course, was not contained until July of 2003. The swine flu outbreak in 2009 and 10, and the MERS outbreak in the Kingdom of Saudi Arabia in June of 2012. The HPA was an executive, non-departmental, arm's-length public body sponsored by the Department of Health, which was accountable to the Secretary of State for Health and the Minister of State for Public Health, but which was operated separately to the Department of Health. Could we display, please, 187830, which is in fact a sheet which helpfully describes the different organisational models of national statutory bodies. And at page 1, paragraph 2, we see described an executive non-departmental public body. Those bodies are normally established by primary legislation. They carry out a wide range of administrative, commercial, executive and regulatory or technical functions which are considered to be better delivered at arm's length from ministers. And existing examples given there are the Care Quality Commission and the independent regulator of NHS Foundation trusts. We'll just leave that on screen for the moment, please. You set out in your witness statement the 5 main roles of the HPA, which were advising government on public health protection policies and programmes, delivering services and supporting the NHS and other agencies to protect people from infectious diseases, poisons, chemicals, radiological hazards, providing an impartial and authoritative source of information and advice for professionals and the public, responding to new threats of public health, and providing a rapid response to health protection emergencies, including the deliberate release of biological, chemical, poison or radioactive substances. So can we see, Dame Jenny, that the HPA's principal role was related to health protection? There are 3 core strands of public health, are there not? Health protection, health improvement, and healthcare public health. The change that took place when HPA was replaced by Public Health England in 2013 to 2021 was brought about in part to make a cohesive change to the 3 core strands in public health. Is that right?
It is. My understanding, I wasn't actually in the Health Protection Agency myself. My understanding was, along with a number of other public bodies at the time, that the intention was to try and, as you say, streamline this. I think partly, or if not mainly, for efficiency reasons, but actually in the for Public Health England, there was a wider remit as well, which I think, as you have been speaking through the inquiry, we're very aware around inequalities and the importance of people's lives, their work, how they live on a daily basis, and how important that is for health protection. So actually bringing together the health improvement elements alongside the health protection gave a potential opportunity to protect on all of those fronts in one organisation.
To help put things again in a historical context, Public Health England was in operation during the global outbreak of Ebola from 2013 to 2016, the MERS outbreak in South Korea in 2015, and of course the start of the COVID pandemic in January 2020. And Public Health England was established as an executive agency of the Department of Health. So returning to our fact sheet, and if we look, please, at paragraph 4 of page 1, we can see that an executive agency is a national body created administratively not legally distinct from its home department, examples including the Medicines Healthcare Products and the Regulatory Agency, Medicines Healthcare Products Regulatory Agency, the MHRA, and of course Public Health England. So it was operationally independent, but legally part of the Department of Health, the Department of Health and Social Care.
It was, but actually, in looking at your that statement, of course, I think the description of the non-departmental public body uses regulatory as a distinctive element, and in fact, we can see here that MHRA is a regulatory agency. So I think what that probably signals is that in theory there is a lot of difference, and in practice there potentially isn't.
Well, one of the differences between the way in which the HPA was created and run and Public Health England is created and run is that there was a direct link, wasn't there? There was a direct legal link between Public Health England and its home department, the Department of Health.
Yes, that's correct, but the HPA also eventually will have reported back up to Parliament, I think, for its use of public money. So, as I say, I think the distinctions are there. They're clearly not entirely distinguished, even in this statement, and in practice, I think they are less differential than perhaps is assumed from this.
Well, as far as PHE's functions were concerned, they were wide-ranging, and as you have already told us, one intention was to bring together the three strands of public health. And its key functions set out in your statement at paragraph 80 include fulfilling the Secretary of State's duty to protect the public's health from infectious diseases and other public health hazards, improving the public's health and well-being, improving population health through sustainable health and care services, building the capability and capacity of the public health system, and developing and publishing the evidence base for public health. Is that right?
It is. I think probably in all of those it says somewhere in partnership, because clearly one organisation can't do all of that, and that was a key component of PHE's work.
All right. Well, in relation to pandemic preparedness and resilience, is it correct that PHE's functions included, but were not limited to, surveillance, the rapid assessment of the first cases and early alerting, testing and contact tracing, providing guidance on border and infection control, the exchange of information with international contacts, designing and running simulation exercises, and managing the pandemic flu stockpile?
Yes, I think just on two of those points, which I'm sure we'll come on to, on testing and contact tracing, I think it's we should not assume that is mass testing and mass contact tracing, which I think we will come on to. Yes. And in managing the stockpile, it is very definitely management and procurement rather than decision on.
All right, thank you. We will be turning to look at that later on in your evidence. And then bringing public health agencies up to date, we now know that the Public Health England organisation was replaced by the UK Health Security Agency. That change took place in 2021, and it became operational towards the end of that year, October 2021. It's right, isn't it, that during the COVID-19 pandemic, the government decided to separate out again the national health improvement, health care, public health and health protection functions?
Yes.
Yes. And so the health improvement functions of Public Health England moved into a new structure called the Office of Health Improvement and Disparities, or the OHID, which sits within the DHSC.
Yes.
The healthcare public health functions of Public Health England transferred to the OHID, NHS England, NHS Improvement and NHS Digital. And the health protection capabilities of Public Health England and NHS Test and Trace were combined into the new UK HSA, a pandemic preparedness and response superbody, which has a permanent standing capacity to prepare for, prevent and respond to infectious diseases and other threats to health.
That's right.
Thank you. So the UK HSA is an executive agency of the DHSC.
Yes.
Is that right? Thank you. We can take that down, please, now. I want to look in a little bit more detail, please, at the changes made to England's public health structures by the Health and Social Care Act of 2012. Would you agree that in 2012 there was a complex restructuring of health and public health services in England, including the abolishing the HPA and transferring its functions to the PHE, which involved the merging of 5,000 staff from over 120 different organisations? I mean, that in itself is quite a task.
Yes, I mean, I think there's a series of different organisational moves which have involved very large numbers of staff and very complex systems working, including the last one.
Thank you. And also the abolition of strategic health authorities and primary care trusts, which were replaced with a number of clinical commissioning groups, and the creation of new arm's length commissioning body, NHS England, which came into force. Also, the Secretary of State for Health was given a statutory duty to take steps to protect the health of the people of England, meaning that at a national level, accountability for health protection would rest with central government.
Yes.
And importantly, giving local authorities responsibility for improving the health of their local populations, which was previously, I think, the responsibility of the primary care trusts.
Yes.
The government's rationale for that change was that many of the wider determinants of health, for example, housing, economic development, transport, could be more easily impacted by local authorities who had overall responsibility for improving the local area for their populations and who were well placed to take a very broad view of what services would impact positively on the health of their local populations and maximise benefits.
Yes, I mean, it returned to the sort of 1970s model of medical officer for health for the community, which I think was important. And if you look at where the evidence is now, after a little bit of a sticky start, I think that's where most people think a Director of Public Health should be in the local authority.
Yes, the Directors of Public Health in England were also given a new ring-fenced budget and a duty to publish annual reports, I think, that could chart local progress. And they were intended to be strategic leaders for public health and health inequalities in local communities, working with the local NHS across the public, private and voluntary sectors, and new proposed local statutory health and wellbeing boards. And in your view, Dame Jenny, that has been a successful implementation.
It was a painful birth, I think, and I say that having taken my own team when I was a Director of Public Health in Norfolk and Waveney over to the local authority and worked as Chief Officer in local authority and PCT. It wasn't welcomed by all, and there were some losses which we might come on to. But I think broadly now, and particularly actually since the last 3 years, it's been very clear that many of those Public Health Director colleagues have really risen to the challenge and are very respected senior leaders in their communities.
Would you agree that the 2012 reforms across the board, relating to mainly the creation of Public Health England, but the other matters that we've touched upon, received mixed reviews from the public health community?
I think that's a fair comment.
The inquiry has heard from Professor David Heyman, who was non-executive chair of both the HPA and PHE, and also from Professor Whitworth, the biosecurity expert, who were both of the view that it was beneficial to have health protection and health improvement under one roof, the one roof of one organisation, because of the cross-learning to be had between those areas and the synergy, as they described it, that was created between them as a result. But on the other hand, others have raised concerns about the structural reforms and problems that have arisen which we're going to look at now, if we may.
If I might just add, though, I think whichever way you divide public health, it goes in multiple different directions. So there is no straight line which works perfectly. And what perhaps you haven't mentioned is the potential advantage of the organisation we have now, which is actually to build up on the science side, which I think has been a little bit suppressed in the last year. So totally supportive of the Directorate of Public Health. But actually, when we get to what can we do to prevent a pandemic,
yes,
it wasn't well placed.
No. Well, we're going to look at the scientific side and how that has been perhaps improved by the UK HSA. But remaining for a moment, please, with Public Health England, because that's the organisation that was in force in the run-up to the pandemic and really throughout the majority of the timescale that Module 1 is looking at. I want to look at 5 potential drawbacks. Confusion over EPRR responsibilities, independence from government, funding issues, capacity issues, and fragmentation of public health services. In his report to the inquiry, Dr. Klaas Kerschel has said, what sounded complicated on paper proved complicated in practice. The blurred statutory overlap between local authority, Secretary of State, and Civil Contingencies Act duties would and could create significant operational confusion over prime protection responsibility during emergencies. Dame Jenny, do you agree that there was some confusion perhaps over roles in emergency preparedness, resilience and response arising out of what is described as a complicated, overlapping or blurred state of statutory responsibilities?
Yes, but I don't think it was a perfect system before either. And so I think what you're potentially getting is a central view out rather than an outside view in. But I agree in principle that it was confused partly because of a number of different new changes. People have to get used to them. Partly because of the movement, which we've just said, I think everybody supports, of the Directorate of Public Health into the local authority.
Thank you. Dr. Klaas Kerschel also has told the inquiry in his report, although it absorbed many pre-existing structures, Public Health England also differed from its predecessors in key ways. In addition to its combination of health protection and promotion functions, it broke with the post-1950s English tradition of statutory non-departmental public health bodies that were set up by Parliament by being integrated as an executive body within the Department of Health. This not only resulted in far greater political control over PHE activities by ministers, but also meant that all employees were civil servants and subject to the Official Secrets Act, a cause of concern amongst public health workers. Do you agree with that as a description? And do you agree that the very close political connection between the organisation and government was a cause of concern amongst public health workers?
I recognise the cause of concern and I recognise the perception. I don't necessarily agree with the content.
All right. Why not?
Well, I mean, I myself at times have been accused of going to the dark side. This is the standard thing. And it's very difficult because, as I pointed out when I did, I was a Director of Public Health one day in a community, and then on the other side the next, I'm just the same person with exactly the same professional skills and ambitions. There is a different way necessarily of working in government to try and achieve the outcomes. And I think the most important thing, as we'll probably see with other systems, is you need the trust of the people you're working with and those relationships. And I think that is important to organisational change.
To what extent did being an executive agency of Public Health England affect its ability to act as an independent advocate for public health and decide its own public health priorities?
So I think there are two answers to that. One is in reality and one is in perception, as I've said. So there was very definitely a strong perception. I can remember when I joined the organisation from, having not been in this area of work at all, was that government was trying to stop everything being published. So the minute you stopped to try and align comments so it didn't confuse the public, it was perceived as government won't let us publish science. And it was entirely incorrect. And in fact, there was a very specific clause inserted in the rule that said there is a right for Public Health England, and we've retained it in UK Health Security Agency, to speak the truth about the science. but there's also how you use that to enable good public health outcomes. And sometimes it's better for the public, for the political context, you'll get better outcomes if you manage that type of relationship, and you almost have to be in it to understand it, and I think that's one of the problems.
So is it important, in your view, for public health advisors to be independent of the government, or at least appear to be independent of the government?
So I like to think I am a civil servant. This is where I have to throw whichever hat I'm wearing up in the air. But I'm also bound by General Medical Council regulations, and I stick to them very firmly. But at the end of the day, I'm bound by my moral compass, which is very definitely set on delivering public health outcomes. So there is a debate here about if you are away from government, whether you can achieve good outcomes, or whether it's better to be closer. But I think a key point is you need both. That's the really important thing, and you need the connections between them.
How important is it for an organisation such as Public Health England to be able to set its own strategic priorities? And is that possible with such a close connection with government?
I think it is important, because I'm sure, a lot of the conversations that have been happening so far in this inquiry are very much about who is raising which issues, are they being heard, and that is part of that strategic direction. And in most cases, they are the experts in the topic and need to do that. Nevertheless, the point you make is they will be to some extent moved by whatever the departmental initiatives and priorities are, and they are part of that machinery. So there is a balancing act.
Thank you. Moving on to funding, please. Could we display two INQ? We've had it already. Paragraph 108. You're ahead of me. Thank you very much. This is again from Dr. Cashell's report, and I just want to focus for a moment on the public health budget, please. Functioning of the new local and national English public health structures was compromised by austerity politics, in his view. At the local level, the abolition of PCTs, primary care trusts, meant that overall public health performance was strongly dependent on local authority capabilities to commission and deliver effective services. Ministers had promised to ring-fence the public health budget for local authorities. However, an in-year cut of 200 million in 2015 was followed by further reductions over the next 5 years. According to the Local Government Association, this amounted to a real-term reduction of the public health grant from over 3.5 billion in 2015 to 16 to just over 3 billion in 2020 to 21. That's a difference of 14%. Other estimates by the Institute for Public Policy Research spoke of an even more dramatic reduction of 850 million in net expenditure between 2014-15 and 2019-20, with the poorest areas in England experiencing disproportionately high cuts of almost 15%. Resulting pressures on local public health were exacerbated by an overall 49% real-term cut in central government funding for local authorities between 2010-11 and 2016-17, and a resulting practice of top slicing, whereby authorities reallocated ring-fenced public health budgets to other services, broadly impacting health and well-being, such as trading standards or parks and green spaces. In 2010, Healthy Lives, Healthy People had promised to give local government the freedom, responsibility and funding to innovate and develop their own ways of improving, public health in their area. Freedom and responsibility had been granted, but funding was often lacking. Thank you. We can take that down. Dame Jenny, do you agree that the ring-fenced public health budget reduced over time due to austerity?
Yes, I mean, those figures, and I recognise some of them. Obviously, I've read the report, but yes. I think they just need to be taken in context. If there are 152 top-tier local authorities and a 200 million cut in a year, we just need to think that's just about $1 million, and we're in. So it's an important million for that local population.
Yes.
But just to put that in context and hold that high. Nevertheless, I do agree with you, and I know that directors of public health were under significant pressure. Local authorities actually were often much more efficient at commissioning services, so they could almost generate savings from that and get just the same public health outcomes, but nevertheless they were significantly under pressure.
But as well as having the opportunity to generate income themselves, the public health budget was reduced even further, wasn't it, by local authorities dipping into it due to cuts to their overall funding from central government, as set out in the piece that we've just seen.
Yeah, and rather than use the word generate, I might just say that it was a lower loss, if like, rather than it wasn't a generation. It's just they could work more efficiently, just for clarity. So I think the way the public health grant was managed, it went through Public Health England effectively. It came out as a top figure from local authorities. It wasn't possible often to see, and we can, I think, may acknowledge that for health protection, exactly the detail of what was being spent where.
Yes.
And it was a very sensitive area for obvious reasons. But I think it's fairly reasonable to assume that local authorities were translating where lives were being protected through the lens which they had at that time.
Do you agree that the poorest areas in England experienced disproportionately high cuts?
I can't comment on that objectively without seeing the numbers, but my understanding is that that's the case.
How did the funding cuts impact on the work of the directors of public health and local authorities generally when it came to EPRR functions, do you think?
So I think it's fair to say, I mean, even at the start, before any of the budgetary changes, whether because of perceptions of people, for example, in clinical roles not wanting to move to local authorities, or whether for other reasons, the changes, people actually, lots of staff were lost in that move, so there was some skill loss. And then increasingly, as people went across, some of the, initially, not now, but some of the Directorate of Public Health roles started to move down the hierarchy within the local authority, and some of the more, if you like, the expensive roles, so some of the ones, perhaps the clinical roles, would be lost. So I think it is fair to say, and I'm pretty confident it's evidence, that some of the health protection skills were denuded, particularly from the smaller local authorities, where you would perhaps have one Director of Public Health, one consultant, and one other, really quite small.
Yeah. In fact, your colleague, Professor Oliver, tells us at paragraph 93 in her witness statement that over the period from 2009 to 2013, regional EPRR resourcing in terms of whole-time equivalent capacity and relative seniority, and that of other teams supporting EPRR functions reduced. And she says that consequently this impacted on the ability of regional teams to undertake EPRR functions, including engaging in multi-agency pandemic preparedness work, and that reductions in funding also impacted on the HPT workforce, which would have had a further impact on EPRR capacity.
Yeah, just for clarity though, those comments relate to the Health Protection Agency EPRR capacity, not the local authority, which is what I was referring to before.
But do you agree,
agree
with what she says in terms of the reduction in capacity? Yeah.
You're moving on, or actually you've got one more, haven't you, for the 5?
Yes, sorry, that was dealing with capacity issues, and I'm just going to deal, if I may, were you inviting me to take a break, my lady?
When you're ready.
Thank you. Fragmentation of the public health system. I'll just deal with this briefly, if I may. Professor Philip Banfield of the BMA has told the inquiry that reforms of the public health system in England in particular led to a fragmented system, with the 2012 Health and Social Care Act fracturing in many places the links between public health specialists and NHS colleagues. Is that something that you recognise, Dame Jenny?
I recognise it as a recurrent theme every time there is a change in the system, and it happens always when there's an NHS change as well. So it's almost if you're working on the front line, you have to throw your rope out to the person you knew last week and see which organisation they've landed in. So I do recognise it, but it's not that uncommon. I think it was particularly difficult over that period.
Do you agree that community infection prevention and control suffered as a result of the fragmentation?
So that was some of the clinical capacity that I was mentioning, that it was a declining resource anyway, I think. So IPC nursing, I know I personally persuaded 2 of my nurses to come across to the council with me. Most places were not that lucky. They mostly stayed in the NHS. Actually, there is and was a strong need for them in the community.
And finally, do you have any comments on how the structural changes might have impacted on staff morale and working conditions, including pay, based on your own experience as Regional Director of the South of England Public PHE?
Within the PHE at the time. So I think pay was standard terms and conditions, so to speak, for different multidisciplinary, but that was not the issue, with one exception, I think, which was for EPRR staff, where the regional layer went, then people were, there was a reconstruction, if you like, and a formal consultation, and several people moved down a rank rather than stayed in their existing roles. So I think that did prove demoralising for many of them. But I think the uncertainty around it, as I say, just trying to find out where the other end of your rope needed to land is unsettling. People generally want to get on and do the job that they're trained to do.
And it created its own pressure.
Yes.
Yeah, thank you. My lady, is that a convenient point?
Thank you very much. I should be back at 3:15.
All right.
Can I, sorry to interrupt, could you speak more slowly, like many of us, and I'm also guilty. You speak very quickly, and I know it's been a very long day for our wonderful stenographer, so...
My apologies.
No, not at all, please don't
I will
apologise.
try and speak more slowly. So in response to your question, so as a regional director for the south of England, I had two centre directors who would report to me, each of whom had several health protection teams. If, for example, let's say it was a capacity issue, they were having problems with recruitment, we would be reporting that back into the executive management team nationally to alert to the fact that there may be some risk in our health protection provision. Alternatively, if they were doing good work and had had some success in a particular issue, then that was an opportunity to be sharing that work. But obviously, it also gave an opportunity to feedback on the local political side as well, and how different directors of public health were working in their patches.
Thank you. There were a number of changes to the structures of the regions and therefore to the management and delivery of EPRR functions over the course of our module time period. What was the impact of those structural changes to the PHE regions and to the regional teams?
So they started with the Health Protection Agency problems, and I think there was something like 28 strategic health authorities when it started off, and then gradually they all got removed, and then we went into PHE regions. The difficulties of coterminosity, or lack of it, was a major problem, and therefore as numbers went down with resource cuts across obviously local areas, but Public Health England teams as well, then those individuals were trying to support more local resilience for directors of public health and local health resilience partnerships. So generally, it meant you were less able, perhaps, to put the same amount of input as you would have done as support into those different areas.
Professor Fenton from the UK Faculty of Public Health, who we've already looked at, said that health protection teams, which moved from the Health Protection Agency to Public Health England, saw successive reductions in funding and capacity over the pre-pandemic years and a lack of investment in regional emergency preparedness, response and resilience teams. And he says a direct result of these changes was a reduction in the amount of professional exposure that the public health specialist generalist workforce had to health protection duties and continuing professional development outside of PHE. Now, first of all, could you help both my lady and myself by explaining what a specialist generalist workforce might be?
I will try very hard. So the Faculty of Public Health and the Royal Society of Public Health, but the faculty sets the standards for public health training. As people go through their training programme, they could become a health protection specialist. I mentioned a CCDC, a consultant in communicable disease control, who's very focused on health protection. Or they could become a specialist generalist, meaning that they were general across all those three areas of public health. But we would expect a generalist still to have basic health protection training and exposures, so that if you have something like a pandemic, they also would turn to support that. So I think what he's suggesting is that if the teams in health protection were getting smaller and perhaps a little bit more fraught and overworked, they would potentially have less time to support that training as the generalists came through.
And is that something that you recognise?
It works both ways, because actually if you have less capacity in your health protection teams, it's a great way to learn, because you get given a whole load of things because there's nobody else there to pick it up. But I think his point is he would be wanting to ensure those people were receiving on-the-job training, and there might be less capacity to do that.
All right, thank you. I want to touch briefly upon the developments in the infrastructure of public laboratories and in the generation of microbiological data, because there are other witnesses who will be helping the inquiry with this. But we've received a report from the then CMO, Sir Liam Donaldson called Getting Ahead of the Curve, which the inquiry has read, and it was a report that proposed the creation, I think, of the HPA. Within that report, there is reference to structural reforms that brought about the creation of the HPA in 2003. Is it right that during the creation of HPA, that the Public Health Laboratory Service, PHLS, was disbanded and merged into the HPA, and that control over all the local PHLS laboratories was transferred into the NHS?
I wasn't around at the time, so I'm only able to give you the information as I understand it. But I think what happened, there were broadly, the Public Health Laboratory Service grew up after the war and had quite a wide reach. At the 2002 reforms, when HPA was formed, around 32 laboratories went into the NHS, and the rest, if you like, the specialist laboratories and public health reference laboratories went to Health Protection Agency, and those are the ones which we retain in the UK Health Security Agency and previously Public Health England.
How did that work in practice?
Well, it meant that the NHS Trust, the hospitals, had their own laboratories attached, and so I presume what Liam Johnson is referring to is he would perceive a fracture, if you like, between the NHS laboratories now and the specialist laboratories, and sometimes you need an alerting system to see where there are cases being diagnosed, and then, if you like, send them on to the reference laboratories to check them out in detail. I think in around 2010, again before I came into the English system, there was a change in data flows, and therefore actually the reporting of data almost automatically then caught up, I suspect, with the concerns of 2002. So in general, that work flows through. We have different issues now, which is around staff retention and training and differential pay issues across the two divides. But I think the data flow issue is predominantly resolved.
Right, thank you. Does the microbiology testing of virus samples require laboratory facilities and laboratory scientists who are specially trained, or is it something that all scientists working within the service can deal with, and can it be dealt with at any of the laboratory sites? No,
so I think for many of the viruses that we will be talking about, and they're very rare before, I draw everybody's anxiety levels up, the Public Health England at the time, UKHSA now, deals with the very highest level pathogens. So we talk about containment level 4, or the highest level laboratories, and those are only situated on 2 sites for what was then Public Health England, and another one which was the government's scientific laboratory at Porton Down. And so none of if we have a case of a high consequence infectious disease case, or pathogen X, whatever it might be that we're uncertain about, they will be managed in a way which goes almost always to Porton Down or respiratory to Colindale labs, and they will be dealt with in those high containment facilities for safety.
And what about the infrastructure of those 2 laboratory settings in Porton Down and Colindale? And the requirement, obviously, to keep that infrastructure updated and safe?
Yeah, so these are major undertakings. They're part, if you like, of the national, well, they are part of the national security infrastructure, and therefore it's absolutely vital that the country retains them. In fact, as we've discussed, I think, through the early part of the inquiry, you can see that the risks of these new emerging diseases developing and the potential for needing to do more research and to use them for vaccine evaluation as well is growing. Meanwhile, they take an awful long time to build. So it's very important that when decisions are being made about health protection, those sorts of decisions in funding and maintenance of laboratories absolutely factors in the time frame for safe refurbishment and building.
Looking back now, do you have any reflections on whether all of the structural reforms had an impact on pandemic preparedness in England leading up to January 2020?
It's very difficult to look back because the comments you've made about fractured lines and the potential, there definitely was uncertainty after 2013 when Public Health England started. We know we've submitted a number of papers where different parts of the system have tried to work, Directorate of Public Health with Public Health England, proactively to recognise different roles and responsibilities. That said, we've also put forward in the evidence a survey which suggests actually that people do understand them. So my feeling is that the overall issue is more to do with capacity rather than roles and responsibilities.
Thank you. You also deal with the funding situation of PHE in your witness statement, and you tell us at paragraph 91 that over the lifetime of PHE, its funding from central government was reduced by over 40% in real terms, taking into account inflation and unfunded pay pressures. Thus, the organisation had to implement the cost savings that this required, so it met its duty to operate within its budget. And in addition, there were budget reductions on the level of funding of PHE's predecessor bodies for the functions that came into PHE in 2013. I'd like to display 90350, which is a schedule of yearly funding for PHE received from the DHSC that UKHSA has produced for the inquiry. We can see the year in the left-hand column and the funding in levels of millions on the right-hand column. And so we can see that the core grant and aid funding that PHE received from the DHSC in 2019-20, thank you, was 287.1 million. If we move further up the chart and further back in time, in 2013-14, the amount was 392.5 million. Is that the 40% reduction that you were referring to?
It is, but it's in real terms, and I think we've explained in the submission, in the statement, how that is derived. But yes, effectively what was happening, not only was the grant and aid dropping, but the costs were going up, so maintenance of these very expensive laboratories, which you have to retain. But also the organisation, therefore, in order to sustain itself, became very dependent on its earned income. It has absolutely brilliant scientists and it can generate some income. But by the end of this period, my view would be that rather than having a system that was a critical system for the UK, founded on a substantial grant that could maintain it, it was trying to pedal fast to keep up, generating income and often using its scientists to do that rather than perhaps strengthen the wider health protection system.
And just so that we understand, although it appears that there is a big rise in funding in the years 2012-13 to 2013-14, that's because Public Health England was a much larger organisation than PHA, wasn't it? And it had to take on many more functions when it was created.
It was, and also there's a change in the middle, and again I think explained in the statement, because it took on some of the child public health programmes, which actually, the overall system went down, but there was an additional grant and aid for that.
Apart from the way in which you've described in your answers just now, are there any other ways in which those funding cuts, which ran in parallel to workforce issues and structural changes that we've just looked at, impacted on PHE's pandemic preparedness functions?
I mean, I wouldn't like to make a particular case for this, in the sense that I recognise at that time almost all public sector organisations had budget decreases, but of course the combined effect of that meant that if the local authority also had insufficient and the NHS had also dropped their numbers of staff, what happened was, when you met round the local resilience forum table, you may not see the person you saw last week because they'd gone to another one. There weren't as many people there to staff. So I think the overall impact was quite significant.
Just pause, please, don't go, sorry. I'm afraid this is a recurring theme in the afternoon. Yes. And it's usually when I'm on my feet.
Don't get paranoid, Ms. Black.
Sorry, I won't. At the back of my mind. Sorry, Dame Jenny. You were explaining about perhaps not seeing the same face around the table.
Concurrent efficiencies in relevant partner organisations is really important to maintain a system-wide health protection response.
Thank you. I'd like to turn now to discuss the interaction and involvement between PHE and the National Risk Assessment and how PHE works to create and provide the important facts and figures and calculations. So could we have on the screen, please, 206659, which is a document entitled Risk Assessment Template, Cross-Government Risk Assessment of 2018, Emerging Infectious Diseases. Is this the document that PHE would have produced and provided to DHSC in relation to the NSRA assessment for the risk pertaining to emerging infectious diseases?
I'm unable personally to answer that directly. I would imagine so.
All right.
Yes.
And because it's dated 2018, from your general knowledge of the system, could we assume that this was in preparation for the 2019 NSRA?
I'm making that assumption.
All right. Who would have produced this document, Dame Jenny?
This is difficult, and I think it would be better to check. The general principle was that DHSC would feed into the National Risk Assessment, but they absolutely would consult with the specialists in Public Health England to ensure that the right information was fed back.
So does that suggest that the first stage of collating the information and performing the assessment happens at DHSC, and that information is then provided to PHE for their comments and additions?
Yes, I think with most of these processes, you have a starting point, and the first question is this still correct?
Right.
I mean, it's a practical issue, which if you've got something on a piece of paper, people will comment no. If you put it open, they're less likely to. So I think you start off with, this is the position as it was last year or 2 years ago. Does this still look right? Are there new risks, or should this change?
I'd like to look at the last two paragraphs on this page, please. And just remind ourselves of the reasonable worst case scenario risk description, or indeed to see how it is in this template document. Over the past 30 years, more than 30 new or newly recognised diseases have been identified. Most of these have been zoonoses, that is, diseases that are naturally transmissible directly or indirectly from animals to humans. The reasonable worst case scenario is an outbreak of a high consequence infectious disease which is airborne. An airborne disease is more likely to spread rapidly from person to person and can make contact tracing more difficult compared to other diseases which have a different route of transmission. Other emerging infectious diseases which are spread through different routes of transmission are explored in the three variations below. Specifically, the current RWCS is based on an outbreak of a respiratory infection in the United Kingdom, which is similar to the outbreak of MERS seen in South Korea in 2015. This has been chosen due to the current risk of this disease and the historical precedent of imported MERS cases leading to outbreaks. However, it should be noted that due to the nature of an emerging infectious disease, there is some certainty as to whether a different emerging pathogen, including one which was airborne, would lead to an outbreak similar to the scenario described. We can see, moving back to look at paragraph 4, that the overall confidence assessment, the likelihood or plausibility, is assessed as being low. Was the reference to infection control procedures a reference to IPC within the healthcare setting or community IPC or both?
Sorry, where is the reference to IPC?
if we look at, in fact, if we look over the page at page 2, I think it's clearer here. If we look at the first 2 paragraphs here, the RWCS is predicated on a novel or emerging infection, that is one that is either globally unknown or very rare in the UK, arising in another country and then arriving in the UK before it is identified. It's possible that a novel infection could arise in the UK first, but this is less likely. Based upon the experience of recent international outbreaks of MERS, the likely impact of such an outbreak originating outside the UK would be cases occurring amongst returning travellers and their families and close contacts, with potential spread to healthcare workers and other patients within a hospital setting. The resulting cluster of individuals with a similar illness could lead to infection control within healthcare settings or other public health measures being instigated which can control the spread of the disease. For MERS, sustained human-to-human transmission outside of close contacts and healthcare workers has been limited so far, and therefore there is currently a low risk of this disease presenting a wider threat to the UK. However, sustained human-to-human transmission in emerging airborne diseases is possible, which is why infection control procedures are critical to the mitigation of this risk.
Sorry, could you repeat the actual question?
Yes, so at the reference in the middle of that paragraph, if we can highlight it, the resulting cluster of individuals with a similar illness could lead to infection control within healthcare settings and other public health measures being instigated which can control the spread of the disease. So was the reference to infection control procedures a reference to IPC within healthcare settings or within community IPC or both, do you think?
As I sound slightly, we just need to take this carefully because I'm not clear of the absolute origin of the document, but I can see a peer-reviewed reference there of 2017, so
yes.
It's going to be 2017 or later, and the reference to infection control will be it says within healthcare settings, but we always have infection control measures in healthcare settings. This will refer to potentially bolstered healthcare setting controls. And I think this work actually was taken forward in the HCID pathway work, which resulted in the commissioning of 5 new airborne HCID transmission control centres, if you like, which were not in the UK prior to this.
Right. When were those? When were those created, and where were they created?
So the names are actually in the statement, but the HCID work, which started after Ebola, which is obviously a contact transmission, but looked at the potential for high consequence airborne and touch transmission. And at the time, there were just 2 contact transmission centres, which was the Royal Free in Newcastle. And so working with the HSE and with NHSE, new airborne transmission control centres, if you like, were created. So this is a direct result of the HCID pathway. And in fact, in 2018, of course, we had a MERS case, appropriate IPC in healthcare settings was put in place, and there was no transmission.
All right, thank you. Is it right that, certainly looking at this document, which appears to have been based on the MERS outbreak, that SARS and MERS were considered to be primarily transmitted via droplets rather than aerosols?
No, I think Professor David Heyman expressed it very well in yes. His sense. The evidence prior to this was that mostly people were infectious when they were symptomatic, and the aerosol generating procedures, so these are procedures where you are, if you like, it's not quite right, but actively pushing air up from the bottom of the lungs, which is different, for example, to having a virus sitting in your nose and it just popping out if you sneeze or passing somebody. So these were, that is how the transmission had occurred, and if we go to the career case, for example, as soon as they had put in good infection control measures in the healthcare setting, then they got on top of the transmission.
Right. And you referred to the evidence that Professor Heyman gave to the inquiry. He described, didn't he, that really the difference between droplets and aerosols is best described by a sliding scale. Droplets
Yes.
being the heavier, larger particles, and aerosols being smaller, so at the bottom of the scale.
But there's also a generational thing.
Yes.
It depends about how forcefully they come out, which is why we have these distinctions about singing or shouting.
Yes. If we can go to paragraph 15, please, at page 9 of this document. Now we can see that according to this risk assessment, it states that the total number of estimated fatalities, there we are at the top of the page, is between 40 and 70. And if we go to the last paragraph on page 10, please. Thank you. And highlight the bottom paragraph. We can see that the number of casualties is based on the MERS outbreak in South Korea, which we've already established. And given this number of casualties, the number of fatalities could range from 40 to 70. Approximately 40 people died in the MERS outbreak, but with a case fatality rate of 34.9, it's possible that up to 70 people could have died. Both figures could be higher or lower than this, depending on how communicable the disease is, as well as how quickly the disease is recognised and prevented from spreading further using infection control measures. Let's just look for a moment, please, also at paragraph 16, which is on the previous page. And we can see that the number of physical casualties is assessed here as being 200. Do you know, Dame Jenny, why that figure was assessed at that level, taking into account that the number of cases in Korea was 186?
Well, look, I don't, and I think I would need to look at this. I'm very happy to do that outside the court and provide written feedback. It's quite difficult to just look at the numbers and make that decision. But clearly, you know, Korea is one setting. I think all of these suggestions or scenarios around reasonable worst-case scenarios are based on what we know and
Yes.
the context at the time, and that's as good as we have. So we know case fatality rate around 35%, and the rest of it is a very sensible, but in many ways a slightly educated guess, unless you've got other parameters.
Thank you. Can we take that down, please, and replace it with 185135, which is part of the 2019 National Security Risk Assessment, which this information fed into. And could we go straight to page 8, please? Thank you. Now, if we look at, without highlighting, if we look at the two main paragraphs under human welfare, going further down to casualties first of all, the total number of casualties here in the document itself is 2,000. And if we move up the page, the total number of fatalities is 200. Now, again, I appreciate, Dame Jenny, that you weren't personally involved in creating this risk assessment, nor indeed in providing the figures that we've just looked at that appear on the template. But in your experience of these matters, are you able to assist as to why, having been provided with the figures of between 40 and 70 fatalities and 200 casualties, those figures could have been expanded to 200 fatalities and 2,000 casualties, as we see in the actual document?
So, as I said before, I mean, I would need to look at the whole document. On this sheet that you're showing me, it doesn't actually mention which disease we're looking at. And so, case fatality rate for MERS was around 35%, but I think for SARS in the early days it was around 10%. So
Yes.
that would immediately answer your question, but I don't have the rest of the information to do that. I'm very happy to take it away and look in more detail.
I think that would be helpful to the inquiry. But on that point, let's just look at page 9, please, and the section titled Human Welfare Confidence Assessment. Can we highlight that paragraph, please? Because what it makes clear is for the number of casualties and fatalities, the lower bound is based on the MERS outbreak in South Korea. However, there is the potential for this to be much higher. During the SARS outbreak in 2003, there were approximately 350 reported deaths in China, although this was where the outbreak was originating. Both figures could be higher or lower than this, depending on how communicable the disease is, which is a phrase that we've also seen in the template, as well as how quickly the disease is recognised and prevented from spreading further using infection control measures. There is considerable uncertainty regarding the impact of the outbreak on British nationals overseas. This scenario has not been modelled by the FCO or Department of Health. The number of non-British fatalities and casualties abroad will depend on the country where the outbreak occurs and the response of the responding health system. For MERS, there have been 2,102 casualties, 733 deaths from 2012 to 17, but for SARS, there were 8,096 casualties and 774 deaths from November 02 to July 03. The figures presented are therefore based on the SARS outbreak in 2003.
Which aligns with what I've just suggested.
Yes. So the figures are provided by PHE, and then they're not simply taken at face value. They will be worked on or adapted or perhaps even given a slightly different scenario in the preparation of this final document. Is that right?
I don't think I would translate it that way,
Well,
in the sense that the information, I don't disagree with anything which is on the screen in front of me now. It's just we're talking about estimates.
Yes.
We have no cases to go on. So it's extremely difficult. All it's looking at is the totality of cases and other outbreaks and the case fatality rates. And even that actually could be over or underestimated depending on how many people were tested at the time. So I mean, if I may, my lady, there is a general point here about the way we're trying to fit viruses backwards, I suspect, either into legal arguments or the pockets of differentials in the risk assessment when they don't fit neatly in each. It's not possible often in civil service terms to actually say unknown in a box because it needs a number in a box in order to generate the next bit of the logic and the money that goes with it. And I think it drives some of these conversations into differentials which are not realistic. We just don't know. This is as good as we get.
All right. I mean, there is a high level of uncertainty within that paragraph,
Yes.
isn't there? Lots of variables.
Yes.
And I suppose to a certain extent, the figures are the best that can be achieved at the present time that the document is created.
But I wouldn't like to suggest, or at least I have no evidence to suggest that somebody has taken some figures in one place and then moved them around in the others. What is stated here looks reasonable.
Right.
It's just very uncertain.
Thank you, we can take that down. The provision of expert scientific advice and contribution to expert advisory groups. We know that PHE contributed to a number of the scientific committees that advised central government and often provided a secretariat for them. As far as you're aware, to what extent were experts provided by PHE able to challenge the views of experts on those panels?
So usually if colleagues in PHE were attending any of those groups, they were there as individual experts. It depends what group it was. And in fact, for UKHSA, we've just done a review and we've identified 19 different government, I mean, just to make the spaghetti even worse, different advisory committees. And then there's a whole load beyond that, which are not government ones, are technical advisory groups. So if they're on a government, there's a government advisory committee, there are rules about how you, and I think you've had those as well, They will be there offering their independent professional advice, and they will be receiving that from other colleagues around the room. If you looked now, for example, we run technical advisory groups, and UKHSA will chair them. And so they would be there as a UKHSA representative. But there are actually a number of places where people will get external advice, including, for example, from the advisory boards, both of PHE and UKHSA.
You'll be aware, I think, Dame Jenny, that the inquiry has heard evidence about the need to avoid groupthink, particularly in these advisory groups. Do you have any reflections on whether or not the PHE scientific experts may have contributed to groupthink or suffered from that as a principle?
I'm smiling because there are a number of words which keep repeating through the inquiry. I don't hold with the groupthink agenda. I think people spoke very freely. They may not all have thought the same thing. And at the end of a meeting, you have to come to a consensus statement and position to support progressing whatever the topic in charge is. But on the whole, scientists are quite outspoken. And I think it was Sir Patrick Vallance who said they actually quite like to be challenged and have to change their mind. It's quite exciting if you're a scientist. So I don't really hold with that. I do recognise that particularly during the pandemic, and actually through lots of incidents, there is a feeling of people being left out of the room. Everybody wants to be in the room offering views, and there has to be a practical limit to that. It should be representative, it should be challenging, you should have the right skills, but you can't have everybody or the whole response stops.
So perhaps the composition of the groups is important to make sure that there is a range of experience and viewpoints.
Absolutely.
Yeah. Simulation exercises. We've received information about several exercises through the course of our preparation for the inquiry. I want to concentrate, please, Dame Jenny, with you on exercise Alice. And could we have up on screen, please, the report, which is at 90431. Thank you. And I think it's possible also to display at the same time a freedom of information request, which was made by a member of the public in relation to actions implemented as a result of this exercise, which is at 191910. If we could put that up on the right-hand side of the screen, please. Thank you. This, as the inquiry has already heard, was a tabletop exercise conducted on the 16th of February 2016 in London to explore the challenges that a large-scale outbreak of MERS-CoV could present nationally to health partners in England. And participating in the exercise were representatives from NHS England, Public Health England, and the Department of Health, as it then was, and also observers from the Cabinet Office, the devolved administrations, and Go Science. If we look at page 5 of the report, please. We can see the objectives of the exercise at paragraph 2.2. To explore and confirm the health capacities, capabilities, protocols and resources, including surge arrangements, to explore and confirm national command, control, communication and coordination arrangements, to explore the capability for contact tracing and quarantining of possible MERS-CoV cases, and to explore and confirm coordination of public messaging associated with a large number of MERS-CoV cases. And if we just remind ourselves of the scenario, it was where a group of people from London and Birmingham had travelled to the Middle East, and 10 days after they returned, 3 of them presented with at 3 different hospitals with flu-like symptoms. After their histories had been analysed, MERS-CoV was suspected, and a process of contact tracing was initiated. And after 2 days, 2 of the cases were lab confirmed, and a further case at St Thomas's Hospital was strongly suspected. Prior to arriving at the hospitals, 2 of the patients had been part of a large gathering, and the scenario then developed with 50 lab-confirmed cases and 650 possible contacts. And various elements of the NHS were under pressure from the cases, and the media had taken a keen interest. There was a general consensus on the need to identify capacity and capability of assets within the health system, and the level and use of PPE was central and considered of crucial importance for frontline staff. It was noted that the learning from Ebola on infection control understanding, although improved, was still not embedded with staff. And also considered important were access to sufficient levels of appropriate PPE and pandemic stockpiles to ensure sufficient quantities of PPE were available. Now, if we can look at some of the lessons and actions identified, and go to page 10, please, and look at action 4. Action 4 was to develop a MERS-CoV serology assay procedure to include a plan for a process to scale up capacity. Now, is that relating to an antibody test?
Well, it's a detection test, yes, a diagnostic test, and that was completed by PHE. And in fact, they'd been working on them since 2011. It's why we had such good early access during the COVID pandemic.
Thank you. In relation to this action 4, if we look to the document on the right-hand side, please, which if we go to page 2, fortuitously, it is set out in the same order, and we highlight number 4, we can see that the answer to this question was that the procedure was developed and used during the management of the imported case in August of 2018. That's the imported case of MERS, isn't it? And that laboratory procedures for scaling up capacity have been well rehearsed across a range of outbreaks. Can you explain what range of outbreaks that capacity would have been rehearsed in relation to?
So if you have a new infection, it would be PHE's role to create the assay, the diagnostic test, and be able to scale that. And initially, you would usually go out to Public Health England laboratories, then out to NHS laboratories, depending on the risk associated with the pathogen itself. So, I mean, when once you have an assay for something, it's. I mean, I'm not an expert in serology assays. That's why we have them. Once you have them, there's a. You've usually got your skill there, although you do need to ensure that they are remain quality assured. So, in terms of rehearsed across a range of outbreaks, I'm trying to think what else would have happened in that intervening period. So I can't offhand think what happened between 2015 and August 2018. It's safe to say that obviously this is an example that it had been rolled out and was available.
Right. All right. Thank you. Can we go to action 5, please, which is on the following page of the report on the left-hand side? Thank you. Now, this is an action to produce a briefing paper on the South Korea outbreak with details on the cases and response, and to consider the direct application to the UK, including port of entry screening. In relation to this point, can we now go to the Freedom of Information request and have a look at whether or not this was an action that had been taken up by the time that this response was provided? The response is that port of entry screening has been found to be of minimal use across a number of outbreaks and has been widely studied. The details of individual cases have not been released apart from the index case. The protocols developed following Exercise Alice were tested in the response to the importation of a case in 2018, which was successfully managed. But in terms of whether or not the briefing paper was ever prepared on the South Korea outbreak with the intention of taking on board the manner in which South Korea reacted to their outbreak of MERS and attempting to learn for the United Kingdom. Do you know, Dame Jenny, whether or not that briefing paper was ever prepared?
So I think what I'm reading here is, and I wasn't at Exercise Alice myself, but what I understand has happened is that the lessons that were learnt from it in terms of the importation of this case and the learning from South Korea was moved into what I would call practical utilisation. So we may well come on to the National Incident Emergency Response Plan. The NIAP gets updated regularly, now on an annual basis, proactively reviewed. And learning from this will get fed into it. But I think, importantly, there will have been discussion, and I think it was in our pack that we sent in, around the clinical management of cases. And that actually went into the doctors' packs, for example, for those people who are on call, went out to the NHS. So there was a clear pathway for managing cases. So depending on whether you want, I think there are two issues here. There's management of the case, and I think we have submitted some evidence that PHE did that. I think the port of entry screening evidence base about whether it works is a separate issue, and I'm happy to talk about that. And then I think there are then port health, which is a completely different issue, and very happy to talk about that as well.
Well, I was particularly interested in the management of cases, but it's
so there was I think we've submitted a document, I think it was 2017, which went through the normal review process in the EPRR delivery group. That was included in the pack. I think it was temporarily held up, not from the doctors' packs, but in order to make sure that it aligned with the HCID pathway that was under development, and that's now out on the website for everybody to use.
So once that was affirmed, then the guidance was given. Thank you. Can we look at Action 7, please, which is on the following page of the report? Page 13. Thank you. To produce an options plan using extant evidence and cost benefits for quarantine versus self-isolation for a range of contact types, including symptomatic, asymptomatic and high-risk groups. Is it right that there was a lot of discussion around the issue of restriction of movement of symptomatic and asymptomatic patients, and whether this should be voluntary, that's self-isolation, or through enforced isolation, which is quarantine?
Not just for this, but for Ebola as well.
Right.
And I was personally involved with many of the Ebola discussions. So I would classify Action Identified 7 as a wicked issue, and one that we might want to return to. One of the problems with this is, it's not something I think that PHE can resolve independently, and I think there is submitted with the statement a document from 2019 after quite a long piece of work about port entry screening, and the two link together because obviously if somebody's coming in, you need to grab them when they come in if you're going to do this. These are very, very difficult decisions for individuals to make. The law needs to support them, and there are costs involved. And the evidence base is often in a completely different direction to political will. And so they're very difficult issues to deal with. So I think PHE, as far as I understand it, had done quite a lot of work on port health. This was one of the areas they'd identified that they needed support from the lead department. It requires buy-in from the Department for Transport, Border Force, almost everybody. And I think it hasn't progressed beyond that.
This issue in particular has a number of possible options, doesn't it? I think in South Korea there was the use of hotels, but then there's also the option of using specific locations as sites for quarantine, and also the legal rights of the restriction of movement of people, and all of that is brought to bear, isn't it, during this discussion? So it's not a simple matter.
It's not at all. Although we, the country has used a managed quarantine service during COVID, but many of those difficult issues.
Thank you. If we just look, please, over to the other document and see what response was given by PHE. It says this background research has been used to develop the current guidance. Any decisions about making this enforceable were outside the remit of PHE, which
is
with what
more or
just
less what
told
I'm
us.
saying, and it does link very closely with the Port House discussion.
Thank you. Actions 8 and 9 are to develop a plan for the process of community sampling in a MERS-CoV outbreak, and also to develop a live tool or system to collect data from MERS-CoV contacts. And if we look over to the FOI document, dealing with 8 first, we can see develop a plan for the process of community sampling. The PHE confirmed that guidance has been produced and is available at the following place, and sample processing will take place in the routine manner adjusted for scale. As part of any incident response, this scale will be determined and then appropriately resourced in conjunction with other responding agencies, and that this is also contained in the first few hundred FF100 enhanced case and contact protocol, which is also available at the above link. And then we see the answer to number 9. To develop a live tool or system, is that there are a range of systems that were employed by PHE and continue to be employed by UKHSA for gathering data from contacts across a range of outbreaks and are chosen based on the scale of the outbreak. They are causative organism agnostic to avoid duplication or processes. Can you explain to us, please, what causative organism agnostic means?
I was going to say, both of those are quite Mr. Humphreys. So basically, what it's saying is there are ways of collecting data depending on the size of the outbreak and the type that it is, and you do need to fit it to that. For example, in fact, if it was not this organism, but a foodborne one, for example, we might be working and looking at local authority systems and environmental health officers. So I think there are 2 issues in both of those examples. One is my other wicked issue for the inquiry would actually be community sampling. UKHSA has actually put in a sort of mini rapid response team to enable that in some cases, but it is not mass testing. And so I think this move from large-scale contact tracing or large-scale community testing to mass testing is one that is not resolved. I think our data systems are much better, but actually it requires infrastructure as well, and we're still continuing to try and build the systems that we had, which were excellent towards the latter phases of the COVID pandemic, but still need both infrastructure support, if you like, and operational utilisation.
Right, thank you. We can put those documents off the screen now. Do you agree, Dame Jenny, using what we've just looked at as examples, that Exercise Alice presented us with the opportunity of conducting important research which should feed into emergency plans, not only for a future MERS-CoV outbreak, but also any other type of emerging infectious disease?
Yeah, I think actually I looked at these with interest because I worked directly on the airport screening for Ebola, and a number of these discussions and problems arose. And then we had this, but at the time that Exercise Alice happened, we were developing proactively the HCID pathway. Which
already?
Yes. So I think to some extent, whereas you might think this would be a stop point to say, let's do something, in fact, a lot of the activity was already happening. What we do now in UKHSA is if we have an outbreak, we immediately put in a research programme at the start that says, what are the questions we're finding that we don't know the answer to? So that we try and kick that off immediately, so it supports, outcome management, outbreak management later.
Yes, it's fair to say though that looking at Exercise Alice and some of the actions or lessons learned that were highlighted, and from the evidence that you've given and what we've seen from the Freedom of Information request, that some of the actions were implemented by Public Health England, even though that was not the commissioning organisation for the exercise. Why would that be? Would Public Health England have taken on had taken on actions that were ordinarily out with their own work areas.
They will always try and do the right thing, and that's often not recognised, so this is a great opportunity to do so. And I tell staff to run towards things if it's important for health protection. But those two issues around port health, and I think we can see that in the work frame there, were there from Ebola. And community sampling is a long-standing issue. So those are two issues which I think the organisation has felt unable to resolve on its own, and it needs wider than DHSC. That's also my point.
Thank you. There was an exercise that took place in 2016 called Exercise Northern Light. I don't want to go to the details with you, but just to say that one of the matters identified during the course of the exercise was that current arrangements with supporting surge centres and partner organisations would benefit from future development in preparation for multiple HCID cases. And I just raise that because I'd like to move on to exercise Cygnus, which took place in October of 2016. And again, I don't want to go to the documentation, but simply to confirm that one of the lessons identified in Operation Cygnus was that an effective response to pandemic influenza, because that was the subject matter of this exercise, requires the capability and capacity to surge resources into key areas which in some areas were lacking. And then exercise Broad Street in January of 2018, which had as its subject matter an HCID outbreak, also touched upon the need for surge capacity. Do you accept, Dame Jenny, that by the time we reached the outbreak of COVID-19 in January of 2020, that there had been lessons identified, warnings given, however you want to describe it, that come a pandemic, whether it be influenza or another type of disease, there needed to be within the health systems of the United Kingdom, public health and also general health, the capacity for a surge in terms of within hospitals, within workforces, and within a capacity in order to try and deal with a significant outbreak.
I do, but I think all of those three things are quite different surge mechanisms, and I'm wildly trying to remember. It's a bit like variants for COVID, which one the Northern Lights exercise was. I think it was Lassa fever and H7N9, which was to try and see if two HIDs, an airborne and a touch, could be handled at the same time, which is, as long as they're small case numbers, it's a different type of surge, whereas Pan flu obviously is a very large national one, and the Broad Street, I think, was checking effectively the pathway that we were just putting in on the HCID pathway. So, and they're checking different parts of the system. There's an NHS surge, there's a whole population public health surge. So I do broadly agree, but I think two of those worked reasonably well. It's the Cygnus Pan flu one, where the capacity obviously was stretched. And there are mutual support arrangements. So each Public Health England centre would support the other one. It would divert calls, or you could have whole regions working. And the emergency response plan outlines that work and allows resource to be flexed. And we can work across with NHSE as well. But I think the Pan flu one is the one is more like the COVID that we've just experienced, and says actually when really stressed, the resources are very, very low.
Yes. At paragraph 106 in your witness statement, you say this, that PHE had identified a gap in national strategy across government focusing on infectious diseases since the 2002 Getting Ahead of the Curve document. Thus, in 2018, it started work on an infectious diseases strategy, which was published in autumn 2019 through a joint launch with the Chief Medical Officer. And you go on to say this identified 10 strategic priorities, including infectious disease surveillance, whole genome sequencing, major emergency response, and health inequalities. For how long had that gap existed?
So I don't think it was a gap in action, it's a gap in focus.
Right.
So the initial Liam Donaldson document from 2002, Getting Ahead of the Curve, was a CMO document setting out a strategic direction and actually forecasting almost the creation of the Health Protection Agency. This one was actually very much more about, it was actually an internal strategy. It wasn't so much a national one, but it had very wide consultation. And it was designed to put some focus and also recognise that there were new developing techniques. So the whole genome sequencing activity is moving us into a completely different realm of health protection with new opportunities in how we manage outbreaks and get on top of them more quickly. So I wouldn't like it to be thought that those streams of work were not ongoing. And in fact, you know, we're just about to publish our own UK HSA strategy for the next 3 years, and the topics will be pretty familiar because that's what we need to focus on. So I would not read an absence into that. I would just say it was far more of, after an internal reorganisation, getting a focus on the topics that were already being worked on.
So is it possible to say whether that gap in infectious disease strategy had any impact on the UK's preparedness for a pandemic?
I mean, apart from the general capacity issues and the financial background, I don't think it did. And in fact, what you can see during that time is, for example, the way that we started diagnosing and treating TB, which is done at the Birmingham PHE, now UKHSA laboratory, using whole genome sequencing, actually progressed very rapid and moved from around a month in detection to coming to a week, and knowing whether you had a multi-drug resistant TB case. So these were actually advances, not going backwards. So I don't think I would accept that.
Before we leave this subject, I just want to ask you, to what extent did PHE seek learning from other countries that dealt first-hand with outbreaks, including SARS and MERS?
So that happens at a number of levels. It works, it used to work, we continue to work with DHSC, who have the prime relationship with WHO, for example. But actually, the previous Health Protection and Medical Director, Sir Paul Cosford, was on the whatever the board level was for European Centre for Disease Control and contributes to that regularly. There are individual groups across. We have experts supporting, in fact, in many ways leading WHO reference laboratories. So there's a lot of different individual professional levels. And again, I know it's a recurrent theme, but I think people are unfamiliar with the level of interconnectivity on an international basis, both on an individual level and organisational. I mean, I might say as well that PHE was part of IAMPHI, which is the Institute Association of National Public Health, International Association of National Public Health Institutes, yet another acronym, and would regularly exchange information, and that happened through COVID and continues to.
Thank you. I'd like to ask you now about the Public Health England emergency planning documents, and two in particular, the CONOPS document and also the NIERP. Did you call it?
I call it the NIERP.
NIERP.
But, it's the national planning document.
Yes. All right. So the CONOPS document, was this updated after 2013?
It's updated regularly and annually, and it had a very big update. I think it was after Ebola. It was around 2016-17.
Right. Okay. And this is the document that details PHE's response to incidents. Yeah. And is it intended to be used alongside the NIERP or the NIERP and also deal with threat-specific plans?
So it's progressed. So it started life well before I was involved within it. But as I say, it's almost come together as a single plan. So an operating process and the background framework, and is agnostic to the threat. But the people who might be involved in it will be decided by the nature of the threat. So, for example, it would manage a business continuity issue when all the steam valves go, supporting one of the laboratories. It's more likely to be somebody on the corporate management side, a senior leader, whereas if it was a high consequence infectious disease, the strategic response director will almost certainly be a medical professional.
All right, thank you. I'd like to look at the pandemic influenza response plan 2014, please, and we can see this at 178938. In fact, these are the minutes of a board meeting of the Pandemic Influenza Coordination Group of July 2019. And we can see that if we move down the page, please, and move to page 2 and look at the first paragraph, we can see that there has been prepared a paper on outline specific functions. As this is a draft, the divisions list in the document are in no particular order. GD, thank those who have already contributed. GD still waiting for a few more sections of PHE to contribute. And then this. Noted that the challenge is that some PHE structures have changed significantly since the last PHE pandemic flu plan was published, so we have to reorganise the document in that respect. For example, NIS was formed since the last plan was published. All right, just pausing there, please. Do you know, Dame Jenny, whether or not the pandemic influenza response plan was updated post 2014 in order to reflect the fact that there had been a change in PHE structures?
I think it wasn't, because the plan was, and I think you may have heard earlier, that Department of Health were due to upgrade their plan, and therefore the idea is that these cascade and follow and link with each other. That said, the National Infection Service was formed of recognised groupings within PHE, professional groupings. So I think it wouldn't be that the plan would be inoperable. And in actual fact, the way that the NIAP, if you'll excuse the acronyms, works is that you have that as the backbone of emergency response operations, and then your plan runs alongside it. So the operational response would still have happened, but you are right, there wasn't a follow-up plan from this. We were, I think, PHE was waiting for the DHSC one to come through.
Right, so no update between 2014 and the outbreak of the pandemic in January 2020?
Yes.
Right, I'm being told that our brave stenographer would like a break in about 5 minutes.
How much more longer have we got to go?
I've probably got about 15 minutes left, so...
Right.
Then I think there's about 5 minutes of questioning from another of the CPs, so...
Let's break now.
If it's convenient to do so, thank you.
5 minutes.
All right.
have a pandemic without some COBRA decision making.
No, but this sentence, as I've just read it out, in the description that it provides about the practical level at which this group would be involved in a pandemic, it is misleading, isn't it?
I think it could be phrased better, let's put it that way. Right. I mean, it predates, well, no, it must have been started when I joined, around the time that I joined PHE, and I wouldn't necessarily have personally been responsible. And sometimes you do look back at documents and you think that was not entirely well articulated. So I think it could be better articulated. I think people will have, those people involved in the response will have known where the wheels were turning, and in fact will have been invited for something like this to contribute either directly to COBRA or through CMO.
But the benefit of a document like this being accurate, not only in terms of its description of the health bodies, but also of the role of a CCS Cabinet Office body like this, is that whoever reads the document is clear about roles and responsibilities, and this, in the two aspects that we've just looked at, could have been clearer and on one level could be described as misleading.
I think I would agree with you. I mean, there are two things I would say. One is I noticed the date is 2014, and I now have the same problem as UKHSA. Every time an organisation changes, you're having to go back and work through documents to try and make them work with the ones before. And it's not just your own organisation, it's the other pieces of the machinery that have changed at the same time, and they're sometimes changing as you're trying to update your documents. So I agree with you. I am less concerned in practice that sentence would have affected how individuals responded. They would have worked to the NIAP and the systems in place.
Because, as you may or may not be aware, the NSC-THRC was retired in 2018 and became completely disbanded by 2019. So, in fact, as we get towards the time that the pandemic hit, that organisation was no longer in existence.
I agree with you. I think it's unhelpful. We're probably, I suspect PHE is not the only organisation with outdated documents, and it's why for things like the NIAP particularly, which is the backbone of response, and I think you can see that through the evidence that's there, it is proactively updated after each incident.
I want to move away from this document now. We can take that down, please. Thank you. And just ask you about a plan, a UK HSE plan for MERS. Is there one in force other than a draft interim response plan that was created some time ago? Do you know whether there's a final plan in force?
There is guidance, and it will be handled along an HCID pathway. So effectively, the practical application is there.
And is it how is it viewed in terms of the level of concern that MERS poses?
So MERS is on the HCID list. So, I mean, in practice, what that means is if we have 10 cases of something else, we say, is this a cluster? Does it look unusual? If there's one case of MERS, somebody's on the phone to me immediately and the CMO knows, and the HCID pathway goes in and the HCID network is activated. So, and we have seen that happen. We've had a Lassa fever case recently. We've had MERS. So I'm very confident. I mean, you will never secure 100% confidence, but it has been rehearsed, and the 2018 example of that is that case was managed well.
All right, thank you. In terms of planning for an HCID or disease X pandemic, Professor Oliver, in her witness statement to us, has confirmed that Public Health England was not involved in any programmes of work related to specific planning for a pandemic caused by any pathogen other than influenza, and indeed that accords with other evidence that the inquiry has received, or indeed any pathogen-agnostic pandemic planning.
Yes. Well, can I be invited to continue?
Yes, please.
So yes, strictly to as you said, that's my understanding. But it does go back a little bit to trying to fit what we haven't got. So the way I see what we have is from a clinical perspective, and I think in many ways probably reflecting what Sir Patrick and Chris Whitty said, is that we have a respiratory virus plan. Currently, I think because the National Strategic Risk Assessment says you have to use an example, and that is geared to flu. And then we have an HCID pathway, which is smaller, but has very high protection. I'm probably preempting some further questions. My view is that the flu plan is actually a pretty good one. I turned around and thought I'd ask the question the other way round. If I was going to choose an example, because that's what the risk assessment says I must do, what other example of a respiratory virus with pandemic potential would I use? And there wouldn't. I'd still use flu because that's the history to date. But what it doesn't have is what I would call a sensitivity analysis. It doesn't do the bits that says, well, what if this flu virus had a longer incubation period, or this flu virus transmitted asymptomatically for 50% of cases? So the actual sort of structures of the pathways, whether it's a new virus or not, feel okay to me. But that's the bit that's missing at a national level, and that would have got us to a consideration of, what is, had we planned for more asymptomatic transmission or a containment phase, as the Hine report suggested.
Yes, but it also doesn't it have an effect on decisions in terms of pandemic stockpiles and clinical countermeasures?
Yes.
Because there was only a pandemic influenza plan, the planning, the practical planning for pandemic stockpiles and clinical countermeasures followed that plan. And so, in terms of antivirals, they were entirely suitable for an influenza pandemic, but as it happened, not for the pandemic that hit us.
To an extent, yes, but I mean, if we did a sensitivity analysis that said we're going to have a new virus that's got 100% asymptomatic transmission, we'll only know if we go into. We'd all be walking around in PPE every day of our lives. So I mean, there is a limit to what that stockpile might ever do, and it's not an unreasonable assumption to put it somewhere around the boundaries that I think it was. But I do think this, however you call it, as I say, I call it sensitivity analysis. We didn't think it should have been flexed to potential characteristics of the virus. The underlying plan is fine, but that isn't, of course, this is the problem. That's not what the NSRA, I think, allows PHE or the Department of Health to do. It gets very specific on it wants to know how many cases, and we have the same thing with COVID, where I will be asked, what is your trigger point? But if you have a virus that is behaving, is a new virus, or you don't know how it's going to behave, specifying a trigger point is not the right thing to do. You need to leave your mind open to what it might do.
What are PHE's responsibilities in terms of stockpiling, clinical countermeasures and PPE?
What were they?
Yes, of course, yes.
Sorry, because I'm sort of jumping between organisations, and actually I wasn't responsible personally for PHE.
No, of course. And sorry, just to remind ourselves that we are dealing with the period of time running up to the pandemic. So that's why I counted the question in terms of
Yes, exactly. So PHE had a VCR team, it's a vaccine and countermeasures response team,
yes,
which was not there to set the parameters of the stockpile. It was there to do the procurement and manage the processing of it and make sure it was stored effectively and that it turned over effectively. And it's quite a complex procurement and management system, which I realise you have a very, very long chapter on that, but important because there is another part of in Department of Health which links with it, and the actual parameters of the stockpile are set through the Department of Health and with input from groups such as NervTag.
All right. I have two topics left. One is the health of the population prior to COVID-19 and the extent to which pre-existing inequalities and vulnerabilities were considered and accounted for in pandemic planning and preparations. Was it part of PHE's functions to assess the nation's health from time to time and also to seek to improve it?
Yes.
Right. And what assessment would you give to the inquiry about the state of the nation's health in the months running up to the COVID pandemic hitting?
I've read Sir Michael Marmot's report, and I would agree with the broad headline. I'll put some caveats. The principle, which I think many people have established and we know, is that infectious disease will follow those areas of vulnerability. And I don't just mean clinical vulnerability, although that is important separately. It will be the vulnerability, combined vulnerability of socioeconomic deprivation, things like housing, and whether people have got good jobs. These are all protective measures for good health outcomes. So I broadly agree. And he says himself, I don't agree necessarily that the causative element, the link between the time frame for austerity and the burden of disease in the population, it's very difficult to draw that conclusion directly. It's possible, but even he acknowledges that.
Right. Okay. So as a principle.
But as a principle, people who are in the more deprived areas will suffer from, they're more adversely affected by infectious diseases, but also by underlying health conditions as well, which combined then creates a major problem.
Right. And although you question the timescale, do you accept what Professors Marmot and Bamborough said about the decline in the 10 years running up to the COVID pandemic?
I think what I'm saying is the objective evidence of decline, you can measure health and socioeconomic deprivation and burden of disease. The bit that's not so easy to do is draw the direct link. They were making a link directly between austerity and that downward trend. And some people will and others won't. And I'm just saying it's difficult to draw that. But definitely the shape of the curve, if you like, is clear. It's evidential.
Over the 10 years leading up to the pandemic. Thank you. May we put up on the screen, please, the report from the Institute of Government, which is entitled How Fit Were Public Services for the Coronavirus? And thank you very much. If we go immediately, please, to page 11, I'd just like to look with you, please, Dame Jenny, at the chart at the top of that page. This is a piece of work that has been prepared by the Institute, and they have, through various pieces of evidence received, sought to draw conclusions in relation to how prepared and resilient public services were at the start of the crisis, providing red for a level of organisational preparedness that was below par or failed, amber for something that was acceptable, and green for good. And we can see that on the left-hand side, the categories are split into preparedness and resilience, and each of those into quality of plans, ability to implement plans, performance going into the crisis, staff, buildings and equipment. And then along the horizontal axis and in the columns coming down from the top, we see NHS hospitals and general practice, local government, local emergency support services, adult social care, children's social care, education, schools, and then the criminal justice system on the right-hand side, separated into police, criminal courts and prisons. The resilience of hospitals wasn't good, but if we look further to the middle of the graph, we can see that both in relation to preparedness and resilience, adult social care appears to have failed. Are those concerns reflected in your experience of these organisations running up to the time that the pandemic hit?
I think I will have to refrain from commenting. I'm a scientist. This looks completely subjective, and I have absolutely no idea on how the ratings have been derived. I mean, I can make a few comments, but just looking at it, for example, hospitals' ability to implement plans if you have no staff, or we've said that the EPRR arrangements are low, feels a slightly strange conclusion. I think in adult social care as well, I mean, it is one of the big problems for social care, and I might add I have personal family experience of this and used to support commissioning in local authorities. So I think, notwithstanding what's on there, I would agree that social care was a high-risk area, and one of the difficulties, and this goes to buildings and equipment and what have you, is it is a largely privately provided service, so the difficulties of ensuring that there are plans that are fit, or that people who are running those services, their responsibility at the start of the pandemic to understand infection control and have PPE ready for their staff, it is really challenging, and I think that has come out through the pandemic. What I do know is they are an extremely vulnerable group of individuals, and I think recognise, and I personally always see this as a continuum for medical care. You can't just exclude one side of it. But I'm afraid would have to refrain from comment on the rest because it's not very evidential.
Well, I had understood that you'd been provided with the report provided by the Institute of Government prior to today, and you would have understood that the findings are based on extensive desk research, analysis of government data, interviews with civil servants, frontline staff, representative bodies and other experts.
But it still has a subjective element to it. I mean, things that I could comment on, for example, prisons, actually in the first wave of the pandemic had excellent outcomes, and in fact PHE is a WHO collaborating centre for prison health, and you can see a marked contrast between the outcomes there in the first wave and the US. But I still think by the time you put those together, somebody has to knit them. So I think that I agree with you in the overarching. The red column in the middle absolutely stands out, and I would agree with it.
Thank you. And finally, I want to give you the opportunity, Dame Jenny, to provide us with your experience and knowledge in terms of what we have been through, your evidence today, but also any aspects that we haven't touched upon, and allow you to assist the Chair in terms of any recommendations that she may want to consider in terms of lessons learned. I know that in particular you were impressed with evidence that's been given to the inquiry about the possibility of recommending the appointment of a resilience minister.
Yes, thank you. It wasn't an idea that I thought I would warm to when somebody first suggested it. But actually, when I look back through my experience and when you look at what I'm calling the wicked issues, one of the difficulties is that these, for example, infrastructure for maintaining very high containment level laboratories or social care agenda cannot be tackled even by a very willing, and I might add Department of Health have worked very hard with us, individual department. It needs somebody, and you see it happening in incident response, which is why Sir Oliver Letwin's contribution was very interesting. I don't say that with a political slant at all. It was very evident that he understood what happened and how you needed to make things work. So I tend to agree. I would add a note of caution, which is just like the rest of the system, churn in the system is a major problem. We lose understanding, we lose connections. And I've had 4 different ministers in the sector in the Department of Health, and you can start to see the difference of people who understand the problems, and then clearly it turns to other things, which is inevitable. So I think that minister almost needs to stay with it for the whole of the parliamentary session almost, for it to maintain the infrastructure for the country. The second point I would make is to do with the science. Again, Sir Patrick Vallance said this, but I think we are, and I think David Heyman said it, we're missing what the opportunities are. This all sounds very depressing and where everything may or may not have gone wrong. But for UKHSA, one of the positive things about having a more science-focused organisation is to work upstream. So in contrast to perhaps where we have been, it's allowing me to put in more systematic horizon scanning and surveillance. We're already starting to work with industry, and we've taken in, so somebody I think mentioned, where has the vaccine task force gone? The answer is, I've got it, and I'm working with it up front because we have the opportunity with new vaccine products, new diagnostic tests, to actually do one of the things that was missing here, which was put equal focus on prevention for the next pandemic, and we have new tools.
Thank you. My lady, that completes my questions. I know that provisional permission has been given to Miss Claire Mitchell, King's Counsel, on behalf of the Scottish COVID bereaved, to ask a question, I think 1 or 2 questions on the topic of Dame Jenny Harris's role as DCMO for England, and may she do that now?
Of course, Ms Mitchell.
We've heard that you were Deputy Chief Medical Officer for England 2019 to 2021. And in your evidence today, you've spoken about connections between governments and organisations, and also the interconnectivity and the benefits of interconnectivity. I'd like to ask you, please, about the connections between individuals and the roles of the 4 nations, and particularly your role when you were Deputy Chief Medical Officer. During your time as Deputy Chief Medical Officer, did you have meetings or discussions with the other Deputy Chief Medical Officers in their roles in the 4 nations?
Yes.
Can you tell me, was any of the work that was done in those discussions and meetings relate to pandemic planning or pandemic preparedness?
So during the COVID pandemic, most of it is obviously, I mean, we're moving on to the next phase almost, so I'm just looking for a signal as to how I should answer this.
No, what we're asking about, I think Ms Mitchell's asking about, is what was the work done in collaboration with the devolved administrations in relation to planning and preparedness?
Up until...
Not response.
In that case, I might decline slightly because, just to explain, although it may not appear that to the nation, there are 2 usually Deputy Chief Medical Officers supporting the English CMO. One of them did the health protection role, which was Professor Jonathan Van Tam, and the other one is the health improvement role. So actually, when I joined the department, it was to support work on tobacco control, obesity, physical exercise, and that sort of agenda. So I would not have expected to be involved in the planning for pandemics. It would be more with the health protection DCMO.
I see, but one of your colleagues would be the person that we would pose that question to then?
Yes.
I'm obliged.
Thank you very much, Ms Mitchell. Thank you very much, Dame Jenny. I think that concludes the questions. Thank you very much to our stenographer for keeping going. I'm very grateful to you for all your help and for your interesting thoughts. Thank you. And 10 o'clock tomorrow morning, please.
Thank you, my lady.
All right.